lots of money each year. And so we need to address it for a number of reasons. We want people to live longer, we want people to live healthier, we want people to have better quality of life, and we also want to control costs. And so it's a big issue that ought to be addressed. And when we ask, well, why, what cardiovascular diseases cause death, what I just showed you is the predominant cause, and that's coronary heart disease. You can see here 48% of cardiovascular deaths are related to coronary heart disease. And so, stroke, heart failure, those are other cardiovascular causes of death, but coronary heart disease is a big one. Like I said before, it's a leading healthcare expenditure when you look at different organ systems and conditions. It's a leading cause for hospital admission. And of course, that can impact costs in a profound way. And what we see is that in the African American community in particular, cardiovascular disease is a big problem. African Americans carry a higher burden of cardiovascular disease compared to white Americans. Risk factors for heart disease, which we will discuss, or appear earlier and more often in African Americans. And of course, social determinants of health and stress and cultural factors also play a role. And as a result, African Americans are living shorter lives due to heart disease and stroke. And if you look at the overall life expectancy of African Americans, it's about 3.4 years shorter than that of whites. And you can see there are differences between males and females here. And you can see over time, life expectancy, compared 1970 to 2012 in this graph, over time, life expectancy is getting better, but disparities remain. If you look at the age-adjusted death rates for cardiovascular disease by race and ethnicity, again, over time, we're making big improvements. We are, decreasing the death rate from cardiovascular disease as we've been able to advance treatments, as we've gotten a lot better at treating acute heart attacks in a very timely manner. But again, disparities remain. You can see here that the highest rates of death are among those in the African American population. And so, mortality from all cardiovascular diseases is significantly higher in the African American population. And it turns out that that explains a lot of the broader mortality differences between African American men and women and white men and women. And the CDC estimates it's can be a third or more than a third of what we see in the gap in life expectancy between the races to be attributed to cardiovascular disease. And so, I showed you sort of the end result, the heart attack. And so we've gotten better at treating it, but we've got to ask the question, how do we prevent it? And that's something that I focus on a lot every day as well. How can we prevent this from happening in the first place? And so we in order to answer that question, we have to think about the science behind it, the pathophysiology, what's happening that causes a heart attack. And so again, it comes back to that vessel and the plaque buildup in the vessel wall. And you can see here in the cross-section areas of the vessel, and these numbers represent decades of life. So in your first decade, you can see here the vessel's pretty clean, second decade pretty clean, and then over time plaque can build up, and then in the fifth decade here you see a plaque rupture with clot formation, and then the artery can remodel after that. And so what we have to ask is, well, how do we prevent the plaque buildup in the first place? And that's called primary prevention. How do we prevent that process from starting or accelerating? Because if we can prevent that, then we can prevent the rupture of the plaque. And then if there is a plaque rupture and someone has a heart attack, how do we optimally treat it so that, one, we can avoid death and comorbid conditions moving forward. We can save the heart muscle in a timely manner so that someone doesn't have problems down the line. And then third, after that, how do we prevent it from happening again? Because stents will cover, one part of the artery. In the patient that we showed, it looked at the right coronary artery, but the patient also has a left coronary artery, and so, which I didn't show you. And so, and by all means, the same process has taken place in that artery with plaque buildup. So how do we know that patient's already had one event? How do we prevent another one from happening? And so, what plays a big role in how we do that are cardiovascular risk factors. We know what contributes to plaque buildup. And the American Heart Association has coined it life's simple seven. And there are seven risk factors that increase the risk of plaque buildup, increase the risk of plaque rupture. And so I'll go through these. These pictures are a little odd, but I'll narrate here. So the first one here is blood pressure. So high blood pressure is a risk factor. The second one, you see a sneaker there. Physical inactivity, lack of exercise is another risk factor. The heart is really cholesterol. So high cholesterol can impact plaque buildup. A poor diet is a risk factor. Obesity is a risk factor. Smoking as well. And then the last one is a glucometer. So elevated blood sugar or diabetes is a risk factor. And so if we really want to prevent plaque buildup, if we really want to prevent heart disease, we have to address each of these individually in order to optimize our chances and decrease risk for a heart attack. And this is sort of a seminal study that was done that really showed how your risk for heart attack or stroke, and by the way, stroke can be a similar process with the brain. It can be a blockage of blood flow to the brain. Sometimes strokes are caused by bleeds, but it's a similar process, and plaquing can play a similar role. So this is lifetime risk of having a heart attack or stroke starting at age 50 for men and women. And you can see here that if you have optimal control of risk factors, your risk is in, lifetime risk in men 5%, women 8%. If you have just one risk factor that's not optimal, that lifetime risk jumps 36% in men, 27% in women. And you can see here that as you have more and more abnormal risk factors, your risk goes up. So this just highlights that having control of risk factors is paramount. And over time, again, we have improved this and in emphasizing the importance of risk factor control, optimizing treatments of acute heart attack. Fewer people are dying these days from cardiovascular disease, which is great. You can see that there is actually a leveling off, though, of this graph. If you can see the blue line is the actual rate of death, and you can see here 2014, 15. It's kind of, we made a lot of progress from 2007 to 2014 or so, and now things are sort of leveling off. And we got to ask why. Well, one is our treatments have gotten a lot better, and so when I first started training, there was a big push on optimizing how quickly we can get in to treat heart attacks, and it was a big focus under 90 minutes, and that was newer, that we really put the infrastructure in place at hospitals and with ambulances to really get systems in place that would allow treatment very fast. And that made a big difference, and it has made a big difference. The leveling off, the current school of thought is that obesity and diabetes, and we'll look at a little bit of data there, is really slowing us down because obesity and diabetes is something that unfortunately is increasing. And so it's counteracting some of the other aspects of improvement. And so these are some of the trends here that we can see. And in adults, we see improvement in, smoking and diet and physical activity and even blood pressure control, as we've raised awareness of the importance of blood pressure control and knowing your blood pressure. And in kids, again, we see improvement in smoking. And the story around smoking has been a big public health success in terms of people not smoking like they used to. But blood sugar and diabetes and obesity remain issues as we move in the wrong direction. And again, if we go back to, yes, death rates are improving, and we're improving in all these areas, but let me just remind you that disparities remain. And you can see in this graph that, yes, even, in all, if you break this down by race and ethnicity, you can see across the board there are improvements made, but there are still these gaps. And so it's really something that has to be addressed. And when we see the gaps, they can really be explained a lot by risk factors and the gaps in risk factors. So take hypertension. The prevalence of hypertension in African Americans is really among the highest in the world, pretty astounding rates. And so that's a big deal, because it increases risks for heart attack and stroke and kidney disease and other issues. Over 40% of African American men and women over the age of 20 have a diagnosis of hypertension. Otherwise, the prevalence in other populations is around maybe 30%. So it's pretty, and it's just been going on for a long time. Historically, this has been a big issue. Diabetes is also more prevalent in the African American community. You can see our prevalence about 22% compared to 11% in whites. And over time, this has gotten worse. And again, diabetes and obesity, or the areas that have sort of have moved in the wrong direction. From 1988 to 1994, the prevalence in the African American community was 8%, and now it's 22%. So I think people are unfortunately developing diabetes at an earlier age. And what that means is, if you have diabetes at an earlier age, there's more time for plaque buildup, over time. And so that's the unfortunate consequence. And you can see here, we've talked about it, the obesity disparities as well, especially, when you look at it again in children, and then you start to get the risk factors of diabetes, hypertension, high cholesterol start at an earlier age. There's really more time for that plaque buildup. Physical inactivity, studies show fewer African American men and women achieve what's recommended levels of physical activity compared to white counterparts. Diet quality has a big impact as well. There are studies that, when you look at different diets that are associated with a higher incidence of cardiovascular disease, they're more prominent in the African American community. I'm from New Orleans, so I know that Southern diet. I like that Southern diet. But unfortunately, that can certainly have a profound impact on some of the disparities that we see. Smoking, smoking numbers are similar. Not, just in terms of looking at the overall numbers, there's not a big disparity, but there's a lower quit rate among African Americans. So as we've made progress, African Americans are less likely to quit. And the thought behind that is that African American smokers use a lot more mentholated cigarettes, menthol products, and menthol enhances addictive potential of nicotine. Menthol is similar to what's in cough drops, so it sort of numbs the back of your throat. So it turns out it's more addictive, and tobacco companies have been targeting African American communities and youth. We'll talk about that later, for mentholated products, unfortunately. And so that has been a big issue. And so the American Heart Association has realized, and this is their 2024 impact goal, that really health equity and addressing these disparities in risk factors in cardiovascular health, you've got to address the disparities to really address the bigger picture here. As long as we have these disparities, then we're not going to be able to really get to the root of the big impact that these diseases have on our population. And so addressing the drivers of health disparities, including social determinants of health, structural racism, where someone is relative to where they have access to care. This is really how we can work to achieve equitable health and well-being and good quality of life for our patients and our community. And so you can see here barriers to health equity, as I just mentioned, still existed. And so, part of being a physician is and can be addressing some of these things that, as a physician, you sort of see the end product of. You see the consequences of. You see the health consequences, and so you can really be a strong advocate and a well-informed advocate for how we need to, as a society, as a community, need to address these issues to address the quality of life for people in the community. And so there are lots of things that you can do as a physician. Not, you address the science, you treat patients, you can do procedures, you can prevent disease, and you can also, and so that sort of addresses personal or individual health. But you can also be a community advocate and advocate for how, as a community, we support individuals in their quest for good health. And that again comes back to our life's simple 7 when we're talking about cardiovascular disease, because that's really what we want to focus on as individuals and our individual strategies for improving our heart health. And so here's the next few slides will be some slides from the American Heart Association that advocate for a tool that they have on their website that you can go to. I'll give the website as well, but it's a guide on life's simple 7s, and it's called My Life Check. And what it does is it's a questionnaire, and it takes you through answering questions about your own health. Now, that includes knowing some of your numbers. So knowing your blood pressure, knowing your blood sugar, knowing your blood cholesterol. And even that first step, just making sure you know those, is a big step. I saw just this morning a post on social media from one of my mentors, Dr. Keith Ferdinand, who's a cardiologist out of New Orleans, has done a lot of work on hypertension. He just posted, know your numbers. I mean, that's one big step, because if you don't know them, you can't know whether they're abnormal and need to be improved or treated. So again, life simple 7s here: blood pressure, blood cholesterol, blood sugar, smoking status, healthy weight, physical activity, healthy diet. This My Life Check takes you through those things and gives you a score based on what you input. And that score, they call it the heart score, and it's on a scale from 0 to 10. And so when you enter these numbers in, you can see how well you're doing or what areas you need improvement on. And you can click on different links, and it gives you advice on how to improve those areas, or whether you should see your doctor, et cetera. And then people can track it over time. So you may check your heart score, in January, and it may be 3. And it said, you got to work on blood pressure, you got to work on weight, you got to work on physical activity, and someone may read the tips and decide how they're going to improve those measures, and then come back, 6 months or a year later, and their score is now 6 or 7. You can see it's a tool that allows you to see how you're doing and what progress you're making or not making. And so, again, blood pressure is a big a big risk factor. And it's a big risk factor because a lot of people don't even know that they have high blood pressure. If you don't know the numbers, most people, high blood pressure doesn't cause symptoms unless it's markedly elevated. And so it's important to be aware and to take action if needed. Physical activity really improves all of the parameters. More physical activity helps improve weight, helps improve blood pressure, it helps improve cholesterol, blood sugar. So that's an overarching um, uh, aspect that you can really make a lot of progress with. Um, Controlling cholesterol, again, high cholesterol leads to more fatty deposits in the vessel wall. And so cholesterol medications, the statins, have really revolutionized our field of cardiology, because when you decrease cholesterol, and you're in turn decreasing inflammatory response inside the vessel walls, and that decreases the risk for plaque buildup and plaque rupture. And so diet is something that's another overarching theme. So a better diet helps cholesterol, it helps blood pressure, it helps blood sugar, it helps weight. So of course, diet and exercise play a role in uh, all of these other risk factors. And so really, you want to eat a well balanced meal, lots of fruits and vegetables, whole grains, nuts, fat free dairy products. Fish is great. So fish and chicken as your proteins, rather than limiting red meats, etc. And then one of the big things, and we've talked a lot about obesity and diabetes, foods and beverages with added sugar are really something to limit and avoid if possible. The sugar sweetened beverages, the sodas, very high in sugar, and part of the reason why we've seen such an explosion of childhood diabetes and obesity. Um, let's see here. It's not clicking through. Weight. So we talked about weight in terms of a healthy weight again affects all of those other parameters. They're all intertwined. The optimal body mass index, which you can calculate with calculators online, is 25 or less. It's based on your weight and height. So knowing your BMI is helpful. It's helpful to work towards a goal and guide your diet and physical activity. Um, and then smoking, it's just a very preventable risk factor, and it's very difficult, for people who have smoked for a long time to stop smoking. The good news about smoking, and this is what encourages a lot of my patients to stop smoking, and oftentimes I'll see a patient, they've had a heart attack, and then we start. Unfortunately, rather than there being a proactive approach, I'm meeting them for the first time after the heart attack. So now we have to sort of work backwards, and we want to prevent another heart attack. And so if they've been smoking for a long time, when you stop smoking, your arteries actually heal. And evidence shows after about 3 years, the smoking that you did before is no longer a big risk factor for you in terms of your risk for cardiovascular issues. So you kind of get a do-over. Not in terms of, unfortunately, lung disease and lung cancer, your risk may remain, but from a cardiovascular standpoint, stopping smoking can be really, really helpful. And oftentimes that's a big motivator. And then diabetes is when someone has diabetes, it has been referred to as a coronary disease risk equivalent, meaning that we really assume that there's some plaquing there, because we want to treat and make sure we get cholesterol down and address all these other risk factors, because we know that diabetes and coronary heart disease really go together. And so this is the website here for this My Life Check, www.mylifecheck.org, as a tool that you can share with family and friends, and patients in the future, to really help in terms of an individual, sort of guiding their own choices and goals, etc. And so I think the issue often comes in is not that people don't want to uh, achieve these goals or exercise more or eat a healthier diet. And sometimes it is, there are choices, but I think as a community, we need to make sure that things are in place to support people making those healthy choices and making those healthy choices easy, affordable, accessible. And so, what the American Heart Association has coined is a term. What we want to create is a sustainable culture of health, a culture of health just among communities where the culture is to limit sodas, and the culture is to not smoke. And it's easy to sort of have some healthy food choices. It's easier to get exercise in during the day. And so, this is one of my favorite slides here. It's a Google search of what is a culture of health, and these pictures come up here, and you can see here the top left corner. This is a picture of an office. These people are having a meeting in an office building. If you look carefully, they're standing, they're not sitting, and they're even on treadmills. So they're walking as they have their meeting. And that's a real, I mean, that's kind of an extreme example. I've never seen that in real life, but that's an extreme example of, they've created a culture of health where, at that company, they're promoting physical activity even during meetings. A lot of people these days will take meetings by going for walks, with people when they have their meetings, and that creates a culture of health. It's just a habit that kind of gets the physical activity going. The middle top picture here are bikers. It looks like San Francisco with buses commuting to work. And so that's a culture of health, biking into work. But what you see is, you need bike lanes. It has to be done safely. So if a community doesn't have bike lanes, you can't really expect people to bike to work. It may not be safe. You need safe communities for that to happen as well. And you can see here that the bottom left, this is a green space design. If there aren't safe parks for people to go to, if there aren't safe outdoor spaces for people to exercise in, it's less likely to happen. You can see here also people gardening and, um, you know, uh, access to healthy food. And those issues are big issues. They're big societal issues in a lot of ways. And access or lack of access to those different resources and opportunities, can certainly lead to disparities. And so, again, a culture of health is a culture in which people live and work and learn and play and pray in environments that support healthy behaviors, timely quality care, and overall well being, where the healthy choice is the easy choice. And so, what a lot of my advocacy work, where it has come in, is looking at, really from a global perspective, from the federal government, state government, local governments. How can we create environments that promote healthy activities in communities? We've partnered with workplaces, churches, neighborhood groups to support that, and then working with individuals and folks with their social networks and friends and family. All of that has a big impact, and we really need to sort of address things at all of those levels. And so we often will work again with channel partners to be able to do those things. And in the Bay Area, I'm proud of a lot of the advocacy work that we've done around building a culture of health around cardiovascular health in particular. And so, you know, a few of those things, and I'll wrap up shortly, and then we can go to some questions. But a few of those kind of wins, we rolled out a few years ago a healthy workplace food and beverage toolkit to give guidance to companies where, you know, a lot of times when you're at work, you have meals, you might have a lunch meeting, et cetera. And so this toolkit really gives guidance to vendors and companies on how to really cater healthier meals. Again, because this is what you're going to eat. If in the vending machine at work or at school there are tons of sugar sweetened beverages and sweets, it's right there. That's probably what you're going to eat. And you know, myself included, you know, if there are little cookies around the office, you know, it's easy to snack. And but if there were fruits, you know, apples, you know, for instance, as the snack, then I'd probably grab that. So it's just creating those environments for healthy eating in this food and beverage toolkit. There's a website for it if that's something that you're interested in looking at.
Chip, excuse me, Chip, I just want to say we got lots of questions and
Okay.
about 7 or 8 minutes, just so you know that. Okay, just for time's
Okay.
sake. Okay.
Yeah, and we're going to 11 o'clock.
I think it's 11 o'clock or 10:30.
It's 11
11
o'clock.
o'clock. Yes. Okay.
Yeah, I
Okay.
just have like
Fine.
3 more
Okay.
minutes, and then
Okay.
we can have
Okay.
lots of time for
Okay.
questions. So we'll do that. These are some local advocacy wins that we've had over the last few years. We've made the default in kids meals. So McDonald's, instead of having the default be a soda, the default in several localities in the Bay Area is now milk or water is offered first. So you can still get the soda, but you have to ask for it. There have been sugary drink taxes in multiple localities that have decreased the usage of sugary drinks. There are changes in how we think about you know, quote unquote junk food and sodas in vending machines in schools or on government property. In terms of physical activity, you know, there are certain recommendations and advocacy work around getting enough PE in schools. Safe streets, we want to really advocate that when new streets are built, new communities are built, or streets are repaired, that there's some thought process behind, is there a place for people to walk? Is there a place for people to bike? So those are some of the programs around physical activity. Tobacco control in recent years, you know, the price of cigarettes have gone up. There have been bans on flavored tobacco products, which are really targeting youth and getting youth into the kind of culture of smoking. You know, the tobacco tax is fairly effective. I have a patient who, you know, I've seen for years, and I just never could get her to quit smoking. And one day she came in and she said, you know, I finally quit. And I said, well, what did it? She said, it cost too much. And so, you know, that's something that we've seen, you know, day to day, that can have an impact. And hypertension, again, a big issue, and the American Heart Association sort of put a spotlight on this with various programs to really motivate hospitals and health systems to get better at controlling blood pressure and prioritizing blood pressure control. There are some self-monitoring blood pressure tools now, something called check change control, where a company can say have a team where participants enroll and track their blood pressures at home weekly over a 4-month period. And then as you assess results and track results, and individuals track results, you get different tools and helpful hints on how you might improve blood pressure. And so when people can work together, and whether you're colleagues or classmates or whatever, or you go to church together, if you can work together and share tips and be motivated by each other, that's another helpful potential tool. And we've promoted a lot of CPR training. CPR in schools since May of 2015 has really become widespread, where it's now a high school graduation requirement for most school districts. And we really push for that, because what I didn't show you is if someone does have a heart attack and they go into an arrhythmia, their heart may stop. And so CPR is really effective. So chest compressions to get blood flow to the brain while you're getting the patient to the hospital so that we can open the artery. And so without effective CPR, you really have very limited time. And so CPR is very important. And so it's something that we've pushed a lot for in schools and even in public places. There are now kiosks where you can learn CPR. You may have seen it in the Oakland airport, where you can learn CPR in about 5 or 10 minutes with mannequins. And so that's something that we pushed. So these are just, this was an overview of sort of, we started off with the case presentation, talk about what is a heart attack and really understand that, understand how we treat it, how big of an impact it is for individuals and also communities, and especially communities of color. And then how do we prevent it, and how do we support individuals and communities in strategies to improve cardiovascular health. So I hope this helps those of you who are focused on this for your community health project, and perhaps it sparks ideas in terms of career-wise in thinking about, as a physician, you can do so much in terms of taking care of patients, but also being advocates for strategies and access and equity that are going to improve the health of our community. So thanks, and we can open it up for questions.
Well, thank you, Dr. McDonald. That was very, very good. I mean, even I've seen this similar presentation, and there are things that I learned that I didn't know. So I'm sure the students all very much enjoyed it. There are a number of questions, and there's shoot-off questions from those questions. First of all, if everybody could turn on their cameras, we would appreciate that. That would really help. As Carolyn loves to take her snapshot of everyone for today. And while you're doing that, Dr. McDonald, I have a couple of questions that came up. I'm going to give you 3 or 4 of them.
Sure.
One, about diet. What is a healthy diet? And 2, if you live in communities where the new phrase of food desert, I just call hungry and no supermarket, no grocery stores, that's what I call it. And you can't get good foods. How can you get good healthy diets? How can you get good healthy foods? Please discuss BMI as an understanding of what BMI is and how does it fit, even if you're 20 years old versus if you're 60 years old. What does the impacts of BMI, and how do you find out about BMI? And one question was about smoking marijuana. Is it smoking the same as if you do it some other way? So I know those are a bunch of questions. Maybe you can catch them all. Okay.
Yeah, sure. So let's start with the diet, and I always get this question, and so there are a lot of sort of fad diets out there that you hear about, and Whole30 and South Beach diet and Mediterranean diet. I think the bottom line, and I don't advocate for any one particular diet, but kind of an overarching theme of a well-balanced diet that consists of adequate fruits and vegetables. So if you go to the My Life Check tool, when you enter in your data, they'll give you advice on, whether you're sort of meeting what is recommended in terms of different aspects of diet. But fruits and vegetables are important. In terms of protein, limiting red meats, limiting fatty foods, cheeses, things like that is important. Fish is very good. It has sort of a quote unquote good kind of fat, and the limiting the sugars, that's a big one. I mean, limiting the carbs, limiting the sugars is will help with just your won't get into detail, but your metabolism, and you'll metabolize more fat, and so avoiding sodas as much as possible and things like that that's sort of a quick way to improve overall diet. The BMI, body mass index, is based on your weight and your height. And so a body mass index of below 25 is considered optimal. 25 to 30 is sort of borderline, and above 30 is obese. And so those are sort of the categories that we use, but really the useful part of BMI is it's something where you can sort of know based on your height what weight you should be, and you can track it. You can sort of over time understand whether you're headed in the wrong direction, the right direction. And age, I believe the question was around age and how the impact is at different ages. And that's a very good question, because all of these things have higher impact when you're older. And so because age is also a risk factor. And so if you are, we use a tool where we calculate people's 10-year risk of having a heart attack and stroke, and age is a predominant variable in that tool. And so even when we think about things like cholesterol, if your cholesterol is 100, and if your LDL cholesterol is 130 and you're 30 years old, we won't treat that with medication. If you're 70 years old, we may look at addressing that, because now your overall risk is higher, and cholesterol is something easy that we can decrease your overall risk. So with that said, the earlier that you develop risk factors, so the earlier in life that there's obesity, and if it's not addressed, then over time there's a cumulative effect as well, where over time now you're that plaque buildup, if you have multiple risk factors earlier on, it can take place earlier, so it puts you at risk for developing heart disease at an earlier age. So I think those things are important to address, and if you address them early, you prevent the cumulative effects that can take place. Oftentimes it's not addressed earlier, because when you think about overall risk, young people are generally at lower risk for heart disease, so it's not really on the radar. But it should be in terms of the risk factors, because there can be a cumulative effect. It's just that it's going to be, as you get older, that effect is just going to be higher and higher, if that makes sense. Marijuana, that was the other question. It is different. We don't see the same impact in terms of tobacco products, and so that's why there's a big public health focus on when it comes to heart disease, tobacco products.
Okay. Why don't we see if someone has a question that they would like to ask? They can briefly and just go straight to the point and ask it. If someone has a particular question that you would like to ask yourselves, and please turn on your cameras.
Someone asked, let me just say, someone asked a good question. Do stents prevent heart attacks?
Right.
From recurring?
Right.
And so it's a very good question. And So stents save lives in the setting of heart attacks. Outside of acute heart attacks, stents improve symptoms. So if someone in the usual symptoms of, so remember, the plaque builds up over time. And so some people don't have plaque rupture, but the plaque builds up so much, it may be 90, the artery may be 90% blocked, and they start to develop symptoms when they exert themselves. Why when you exert yourself? Because when you exert yourself, the heart requires more blood flow at that time. And so people will come in and say, you know what, I used to bike, 5 miles a day. And now on the second, now I get chest pain. I can't do that anymore. When I stop and rest, or when I go up a flight of stairs, I get chest pain. When I stop and rest, it goes away. And that is they didn't necessarily have plaque rupture, but they've had plaque build up over time and they're symptomatic. Then we go through a stress test and decide whether to do an angiogram, put a stent in to open the artery to improve their symptoms. And I often get the question, well, is this preventing me from having a heart attack? And it's a little hard to answer, but the data suggests that the way you prevent heart attack is through the risk factor control and the medications for risk factor control. And so if someone's asymptomatic, they're not having any symptoms, you could, medical therapy for risk factor control is a reasonable option. Selfin, I think you're on mute.
You're on mute.
Okay, I'm sorry. 2 questions. 1, the impact of salt, and 2, the impact of sitting. Because everyone here, as we all know, are on our computers or phones, and we're sitting. Is that the new kryptonite? I don't know.
Yeah, I think the more activity you can get, the better. I think standing, now you have some offices desks that lift up, and I don't know what the data is in terms of stationary standing and sitting and how much you have to do that to make a difference. But I think it does increase activity, it increases movement, and so I think it is helpful. What was salt? Yes, salt can certainly play a role in increasing blood pressure, increasing fluid retention that we often see, and so that's part of the My Life Check questionnaire, is whether you add salt or to food at home, because salt can affect blood pressure. There's some debate out there about how much it can affect blood pressure, but it certainly can have some impact. I see some hands raised too.
Right. Who wants to go? Whoever raised their hand, go for it.
Amber had her hand raised first, so why don't you unmute and ask your question?
Hi. Thank you for answering all my questions. But I had a follow-up to the one about diet.
Mhm.
So you mentioned, well, the AHA, I guess, mentioned that low-fat dairy is a part of the heart healthy diet. So is that necessary? Are they saying, is that I'm trying to figure it out. So is low-fat dairy necessary for a healthy heart? Because a lot of people of color cannot tolerate dairy. So what do we do with this information? Is there an alternative, or what do we,
Yeah, I think the emphasis is on, if you're gonna, what types of dairy are better or worse. I don't know if your question is, well, do I need to seek out some dairy that, I think there are other reasons to have dairy in terms of overall health and calcium and bone health and things like that. And so from a heart perspective, I think the low fat dairy is better. I can't really speak to sort of what the overall recommendations would be for just dairy in general. I think, just because I think that other organ systems and whatnot can benefit from some dairy. So I can't really, that's beyond my expertise in terms of what the recommended levels would be.
And
But
Amber, you may want to talk to your primary care doctor, who is either family medicine or internal medicine, or if it's a pediatrician for that matter, they can talk to you about that if you have that kind of issue with dairy products. So, maybe it's yogurt or whatever it is, or ice cream or whatever you're trying to adjust. But talk to them, because they really are, kind of hone in on that, and then work with, if there's a cardiologist involved, can work with the cardiologist too. Okay.
Okay.
Great. Thanks.
Does that help? Okay. Arisa, is that Arisa?
Yes.
Okay. Your question?
My question was, like, prevention-wise, for those who are maybe up in age that may have lived an unhealthy lifestyle, like through their 30s, is the damage done on your coronary arteries, or can a change in lifestyle reverse the damage done?
Change in lifestyle can definitely help, especially at that young age, in the 30s, because while plaquing can start at an early age, you really see the kind of acceleration later. And so I think a change in lifestyle can make a big difference. Like I mentioned, with smoking in particular, your arteries kind of, you can kind of think about, like, your arteries kind of revert back to what they would have been had you never smoked. If you stop smoking, it takes about 3 years for that to happen, where your risk is then similar to non-smokers. So and I think for the other things, like exercise and weight and blood sugar and things like that, I think getting those under control as early as possible helps. But there's always I think that there's always potential for, even if there is some plaquing there, for some healing, for some decrease in inflammatory changes, some remodeling, that can be quite helpful and have good long-term benefit.
Okay, Michael?
Yes, I think two of the other ladies had their hands up first. If they want to ask a question.
Oh, okay, I didn't see them. I'm sorry.
Iana?
Okay, yes.
Hi, so my question had a follow-up question about BMI, because recently we've been hearing a lot about it's racist or discriminatory towards people of color. So how, is it still a good tool to use even with some of those findings coming out?
Yeah, so I'm not exactly familiar with was there a study recently that came out?
Yeah, there's been recent studies that have stated that the BMI, there's structural racism, and when it was
Oh,
created,
yeah, I
they
saw that.
didn't use a diverse enough group of people for the BMI to really reflect the population. And so basically they didn't include enough people of color get a good standard for the BMI.
In terms of those definitions, I got you. So what is overweight versus obesity versus
Exactly,
et cetera. And we've seen a lot of that across other fields too, in terms of how you classify kidney disease and other things that have had sort of not optimal or race-based factors in equations that we're finding are problematic. So what I would say to that in terms of BMI is, the helpful aspect of BMI is that it's something that you can use to track. And so as an individual, your BMI can be, one thing, and you may, with your physician, set some goals around where you want your BMI to fall. And then you can follow it over time and use it that way. I think that in my mind, that's still helpful.
Thank you.
I can go next. Thank you so much, Dr. McDonald, for
Pleasure.
such a awesome presentation that I think we can all really connect to in one way or another. And I wrote down my question to try to make it a little more concise. So I was wondering if requiring angioplasty procedures at a certain age, like 50 years old, could help us to prevent heart attacks, since angioplasties tell us, at least what I'm aware of, is they tell us how much plaque buildup there is, and also if there are any blockages in the arteries. I've seen with my own family members that procedures like this are typically only used once there are symptoms present. And I know that is a very expensive procedure as well. So I wondered if that could help us like reduce the number of heart attacks.
Yeah. So good question. And remember that procedure is also an invasive procedure. So it has risks. Every time we do procedures and things like that, there are risks. There's a risk of bleeding. There's a risk that we could damage the arteries that we're going through. There's a risk that the contrast material that we use to inject can affect the kidneys. There are all sorts of risks. And what in medicine, we always balance benefit versus risks. So we want to make sure that something's beneficial, and we want to make sure that the risk is acceptable for what benefit we expect to get from it. And that balance is important. And I think that will sort of answer your question here, in that, again, when someone has a heart attack, there's a plaque rupture, there's an acute event. And the data show that most of the time when that plaque rupture occurs, it's from a plaque that may be about 30% block, causing 30% blockage, maybe for years and years and years, and then it ruptures. And we typically wouldn't do angioplasty or put a stent in unless a vessel is at least 70 or 80% blocked, because medical therapy for the others is more appropriate. Because you can decrease, plaque burden, decrease risk of rupture with, for instance, cholesterol medicine, blood pressure control, blood sugar control, et cetera. And typically, the blockage, the degree of blockage needs to be about 70 to 80% before someone has symptoms from it and before it affects their quality of life. So doing an angiogram, and I think you mean angiogram, where you go in and kind of look at the arteries, either invasively or there are some non-invasive methods to do that, really need to be teased out in terms of how are we helping the person? How is the person going to benefit? And, we're not necessarily in a stable setting. We're not necessarily preventing a heart attack. Remember, with stenting, we're improving symptoms. And so we're preventing heart attack by controlling blood pressure and controlling cholesterol and controlling blood sugar and stopping smoking and exercising. Those things prevent heart attack. So that's what we focus on in the prevention world. Now, there are different tools that we can use that are not invasive, that don't carry as much risk as an angiogram, as an invasive procedure, like stress testing and things like that. And that's again, also very specific based on what a person's risk profile is, if they're having symptoms, in terms of how we decide whether or not someone should get a stress test. But we don't require any of that, nor do I think we should, because you always have to take an individual assessment and weigh the benefits, potential benefits and risks to doing a procedure or a test before you embark on that. And so that's best a decision made between, the patient and their doctor in that scenario.
Thank you so much.
Sure. I do want to just quickly give a quick overview of how if you're interested in cardiology, how you become a cardiologist. So after medical school, cardiology is a subspecialty of internal medicine. And so you'd first do an internal medicine residency, which is 3 years, where you learn all of the specialties of internal medicine. So not just cardiology, but also pulmonary or lung, kidneys or renal, infectious disease. You learn all of those different aspects. And then if you decide to subspecialize in cardiology or one of the other subspecialties, you do a fellowship. And so typical cardiology fellowship is another 3 years. And then you can subspecialize within cardiology to do interventional like stenting and angioplasty, or focus on the heart rhythm, which is electrophysiology, or focus on congestive heart failure and heart transplantation. There are different fields there where you may do an extra year or two to get that subspecialty training. So that's just a general overview of how you get to that point. And as you go through your path, you'll find out what you like and what you don't like and what you enjoy doing, and that will sort of guide. You want to get as much experience as you can so you can figure that out, and that will guide your pathway in terms of what training you seek.
Michael, you had your hand up.
Yes. Yeah, thank you, Dr. Nolan, for that information. So I guess a follow-up on that is, can you kind of break down what a typical day looks like for you, or how much of your time you're spending doing those procedures that you had mentioned versus just seeing patients in clinics, and then maybe other responsibilities you may have?
Yeah, sure. And so my day evolves, my career has evolved as I'm doing more different types of work. And that's one of the things that I like about cardiology, is that there are different aspects to it where, for instance, last week I was rounding in the hospital. And so I'm seeing patients who are acute, inpatient. I may do procedures on them, and do consultation. So the ER may consult me for a cardiac case. The hospitalist, who's the internal medicine doctor coordinating the patient's care in the hospital, will call if there's a cardiac issue, arrhythmia, whatever there is, and I'll come in and act as a consultant. Also, and that's where, in the hospital, most of our procedures are done. And so there are a number of different types of procedures done within cardiology as well, like I said, depending on your specialty. So I showed you the interventional procedure. There's also electrical procedures like pacemakers, and there are ultrasounds of the heart that are done as well. And so that's kind of the hospital aspect of it and the procedural aspect of it. And so sometimes my day is spent, I'll have a week straight, doing those things. And then the next week I'm more in the office, seeing patients in the office. Sometimes it's interspersed, where I'm in the hospital one day or maybe a half day, and I'm in the office seeing patients the other half of the day. And so seeing patients in the office is a lot of times follow up from when I saw them in the hospital, or patients who are referred to me for consultation from their primary care doctor for a cardiac issue. So let's take one of those days. If I start off, I see patients, say, in the morning. Another aspect of what we do is testing. So stress test, ultrasounds of the heart. It's called echocardiograms. I also read those. So I'm board certified in nuclear cardiology. And so there's a little bit of radiology in cardiology as well, where part of my day is spent interpreting studies, interpreting ultrasounds, interpreting stress tests. And it can do that in the office or in the hospital. So I really like, kind of, my day has a lot of different aspects to it in clinically, because I'm sort of jumping between seeing patients in front of me, whether in the office or in the hospital, and also performing procedures and interpreting studies and some radiology aspects. I'm also involved in administration and leadership of my medical group. And as I discussed during the presentation, have worked a lot with the American Heart Association in terms of community work. So all of that gets weaved in as well. And so I think as your career develops, you kind of understand what are the types of things that you like doing, and how do the different specialties sort of line up with that, and what the day looks like and what the week looks like is a great question to sort of get a sense for that.
Adrian, you had a question?
Yeah, I did. My question is about BMI. I know we talked a little bit about this with other people in the group, but particularly in my case, two people can have the same BMI and live totally different lives. So for instance, I'll refer to my case because I think I'm very comfortable with my case. I have a BMI of 33, and it's over 25%, which was healthy. My issue with it is, however, that I'm 5'7" and I weigh 215 pounds. However, my body fat is extremely below average, so it's about 12 to 10%. Versus, let's say some other person on the street who also weighs 5 foot, it's also the height of 5'7", 215 pounds, but their body fat is significantly higher than mine. So, like, my issue is with BMI is that two people who have lived totally different lives can have the same BMI. However, the way in which it's measured is kind of, I think, a red herring if we're considering it in the medical field. I think we can use other tools in order to, discuss, have a calculation or a reasonable discussion about, BMI being used. So using bioelectric impedance to discover a person's, break down where the weight actually stored, because we know fat will put more strain on the heart than muscle. So, those are things I'm just kind of thinking about, because when I first read about my own BMI, I thought I was extremely unhealthy. I was like, it's me going to the gym, working out, and, taking care of myself, actively having a negative effect on me because I'm doing all these things. Especially in the bodybuilding world, it's common for people to get heart attacks as well. So it goes both ways. Putting more strain on the heart is something that definitely weighs on the bodybuilding world as well. So
let me just chime in.
I think what you point out is an important point. A lot of nuances to everything that we do, and a lot, everything is not, you're right, is not the same. There are nuances, there are variations that are important and important considerations. And so those are the limitations of the tools that we use, and that's why it's important to sort of individually address these issues with your physician. And they're not perfect. It's somebody who has a perfect BMI, perfect blood pressure, perfect cholesterol can still have a heart attack. I mean, sometimes we see that because there's a genetic component. There are all sorts of things that come into play. And so overall, I think how we think about it is, how can, what's risk, and what do we know increases or decrease risk overall, and how can we impact that in a positive way? And the nuances and the individual aspects, which are totally appropriate to point out, are going to be certainly ought to be addressed too.
So it's not used as
okay. Oh, I'm sorry.
Yeah,
We're just trying to keep the questions, because it's 11 o'clock.
Yeah.
And we okay. And we're trying to make it a general. We got one more question now. Who was the last one, Carolyn? I think it was one more.
I think we've taken care of all the questions, and the last person dropped their question into the chat.
Okay. Antonio, I know, had a question. So Antonio, if there's something more, just let us know.
We wanted to know what the hardest part of being a cardiologist was.
Okay. Look, right now, I think we're running a little behind time. We want to give you a chance to break and for the next panel to come in. But I just want to reiterate, first of all, thank Dr. McDonald for this fabulous presentation. And just keep in mind, everyone, that this is only the BMI and all these other things that Dr. McDonald, it's only one tool. Collectively, you have to put them together. So you can't just look at your BMI and get freaked out behind that. Okay, you got to look at all the other things too, your diet, your genetics, even for that matter, I'm sure. So
Yeah.
just keep that in mind too. And so when we present these, we're presenting these as tools that you should use, not just one thing to point, and then you kind of get, stuck in that mode and worried about that one thing when everything else is fine. So understand it's also about your individuality and you being the person you are. So with that said, thank you,
Great.
Dr. McDonald.
Thank
you.
Salva.
Thank you.
And feel free to share my email. If folks have other questions or want to reach out, please feel free to do so.
Okay, and then we will post the presentation as a PDF on the website, if that's okay with you, Dr. McDonald?
Sure.
Okay,
Yeah.
And so we'll try to get that up in the next couple of days. If he sends that to me, or Donna, our web person, will put it up for us, okay?
All right, great. Good luck.
Okay,
Good luck,
all
everybody.
right. You guys take a break. How long do they have, Tracy and Carolyn?
Until 11:15, we're coming back.
Okay. All right, everybody. Sorry, I know there's a lot of questions, so we're trying to keep it a little bit on schedule. Take a break and come back at 11:15. Okay, everyone. Hi, welcome back. Listen, we had one major announcement that Dr. McDonald wanted to provide for you guys before we go into the next panel. And just keep in mind that the announcement that he is making is primarily for those students who are in the East Bay about an internship that he would like to discuss. And primarily in the East Bay, we mean that can get to, that's Emeryville, Oakland, Antioch, Castro Valley, San Leandro, Berkeley, possibly San Francisco, if you can get over to the East Bay, because this is a fabulous opportunity. Some of you who I've already sent the internship information to, but he's the point person, and you have 2 minutes.
Great. Yeah, I'll be really quickly. Thanks,
Okay.
Delphin. If you could allow me to share my screen, I could share a slide. But
Okay.
what we're starting this year, so my medical group is affiliated with Stanford Healthcare in the East Bay. And we are sponsoring and launching a clinical shadowing program that's a 6-week paid internship for students who are interested in pursuing medicine and who are from underrepresented backgrounds in medicine. And so the internship will start on June 13th, I believe it is. I'm going to I can share my screen now. So I'll put up a slide here with some information. We were originally targeting high school seniors and early college students, but really the requirement is just that you're 18 years or older. So you can be at any level and apply and commit for the 6 weeks. What we'll do is we'll rotate through different clinical specialties, and we'll also have weekly didactic sessions talking about your experiences and invite speakers in to talk about their journey to their career in medicine. So would love for you guys to know about this and apply. And the email address, and this is on the application, so that the email address where you can get an application, if you have not heard about this already, is right here. It's called University Medical Partners at stanfordhealthcare.org. If you see that. And the application is pretty simple, pretty straightforward. And you don't have to get letters of recommendation. You just have to give us people who we can call or email, at least one reference. So I know the time crunch for this group, if you haven't heard about it, is pretty short. So it's pretty straightforward if you're interested, and just email that address if you have further questions or need an application.
Okay. All right. So again, those people who are in the East Bay or who can get to the East Bay, to one of those cities, because that's where the hospitals and the clinics are that you will be going to. Please send in the chat. If you are interested and would like to apply, submit your email address and your name. I guess your name will be up there. But anyway, so I will know in case I missed you when I sent out the email last week. Okay. Thank you, Dr. McDonald.
Great. Thanks, everybody.
Okay. All right. All right. So now we are moving to our next wonderful panel. This is a little bit of different twist. This panel are primarily at the medical schools. These are people that are doctors that have information about something that you all want to know about, is how do they decide who is admitted to medical school? So you guys heard all of the prep information from Princeton Review, from AAMC, and from other speakers about how to prepare. Now you've prepared. So now these folks, these doctors, these teams of people in admissions have to decide who gets selected, who gets admitted. So your questions should be directed in that way. So it kind of be clear, and also will help everyone that's listening to. So with that said, I would like to first introduce the moderator, Dr. Renee Navarro. She is on the PMF board, and she will explain some wonderful, wonderful information. She's at UCSF, and I just love her to death. So thank you, and Dr. Navarro. Okay.
Thank you so much. And just a little sound to be able to hear me okay, because we've had some
It's a little breakup. Can everybody hear? Tracy, can you guys hear?
It's a little staticky and breaking up.
Okay, let me switch my sound here. I'm sorry for this.
That actually sounds better.
Yes, right now you're sounding good.
So talk, Renee. Let's.
Oh, get it out though. I can actually hear it in my.
Yeah.
Sorry. Let me try one more time. Okay. Let's try. So I'm going to switch to my microphone on my computer to see if that's better.
Yeah, it sounds better.
Sounds better now. So let's try this. Hopefully this will be clear for all of you. Good morning. It's a pleasure to be here, and it's a pleasure to serve on the board for the Physicians Medical Forum. As Stefana Bello said, I'm Dr. Renee Navarro, and I am just so pleased to be able to moderate today's session with you. So here we're going to talk about the nitty-gritty. So you want to be a doctor, here's what you need to know. We want to give you the inside scoop on how our admissions office is really looking at candidates, and so you'll have that leg up. We have a very distinguished panel of medical school leaders here to really share that information with you. I will go through and ask each of our panelists to introduce themselves and really tell some of those tips and how we're doing admissions a little bit differently during this time of COVID. I want to start off by having each of us introduce ourselves, and I'll start by telling you a little bit about myself. So I am a physician. I am also a pharmacist, and I attended pharmacy school at the University of the Pacific. And because of the fact that I didn't know what I wanted to do, even though I had an interest in medicine, I came to medicine a little bit later than many candidates, in a sort of untraditional route to getting here. But once I realized when I had the capacity to do medicine and I saw a path and had identified some mentors, I was able to come to medical school. So I joined UCSF as a medical student after graduating from pharmacy school, and practiced pharmacy to really pay my way through medical school. So I am currently a professor of anesthesiology and perioperative care, and we can talk a little about that if you have questions specifically about the role of an anesthesiologist. We are doctors who care for patients in the operating room, in labor and delivery, intensive care, chronic pain management, and really for emergencies throughout the hospital. I tell people that I'm your heartbeat to heartbeat doctor, and that's really my role, is to keep you alive, pain-free and safe. I'm also an executive leader, and I've had many different aspects of my career at UCSF, but I am currently serving as the Vice Chancellor for Diversity, Equity, and Inclusion and the Campus and Health Systems Chief Diversity Officer. I started in this role about 10 years ago, and I'm the first Black woman to ever be a Vice Chancellor at our institution. And we're really leading the way in diversifying our learners, our faculty, our staff, teaching transforming our organization to one that is anti-racism and anti-oppression of any kind. And so I've been pleased to be able to do this work. What I can say to you as a preface is that, we need healthcare providers of color. We need Black doctors. We have a persistent disparity in our health and the health of our communities. And, from the COVID pandemic, the disproportional impact on Black and brown communities, and that the racism that exists within the policing also exists within education, higher education, in medicine, in our professional schools, and really across the health profession. So we're looking for well-rounded, capable, empathetic, and curious questioning individuals who are going to join the health professions. We need individuals who have a passion for helping others, but also understand that there's a privilege to the wearing of the white coat, and that you really have to advocate for change, and that you really need to be health justice warriors. And so with that, I will just take a minute to ask our distinguished panelists to introduce themselves and tell us a little bit about them and some of the tips that you need. And we'll start with Dr. Charlene Green. Dr. Green.
Hi, good morning, scholars. Good morning, good morning. So happy to be here. Thank you to PMF for inviting me once again. I've been a longtime volunteer for PMF and really, really enjoy talking to all the young scholars that are the next generation of the healthcare field. So I'm Charlene Green. I'm at UC Davis School of Medicine. I have a couple of hats there. I serve as Director of Admissions, our Office of Student and Resident Diversity. So that's all of our outreach programs and pathway programs, all the way up through our residency programs. I also serve as the Director of Student Development, which is kind of all of our retention programs. So the extracurriculars you'll do in medical school as you figure out what kind of physician you want to be, and you get experiences that make you a competitive candidate for residency. I'm also part of a National Center for Diverse Healthcare Workforce. It's a research center. So I actually have a doctorate in psychology. So I'm not a medical physician. So I actually use my doctorate quite a bit in my field to do research on different things within admissions, different things with among our workforce patterns. So the students we admit, where do they go to serve? How people perform in our interview process, looking at that as predictors of how they might do on our clerkship rotation. So I get to do a lot of research in that field as well. And I also teach a couple of courses and facilitate a couple of seminars within our medical school to our students. So I do a lot of different things, and it's really fun. I say all that to say, whatever career you choose, I think if you have a passion for things, I love mentoring, I love talking to scholars, you can mold your career in the direction that you want to go and have access to do a lot of different things throughout your career. I was actually born and raised in Stockton, California, from South Stockton, so shout out to the 209 people. I'm sure I'm forgetting something, but I've been at UC Davis for now 12 years. And I've enjoyed it, and I've really enjoyed the growth and opportunities that I've had there. And I've also really enjoyed the mentoring and the opportunity to demystify this process to scholars, particularly those from underrepresented backgrounds. Our school this year is currently number 3 for the most diverse medical schools in the country. We are number 8 in primary care, so producing primary care physicians. And what that means is about 50% of our students go into a primary care field, which is a severely, there's a physician shortage of primary care physicians, particularly in areas that are rural in our Central Valley area. So we're really wanting to build more physicians in California that will serve those underserved areas. But equally as important, the other 50% of our students go into different specialties that are not specifically primary care. So we're really, again, into whatever you decide to do. We are really hoping to build physicians who want to go to areas where communities and patients need them most. So I'll stop there and allow my last colleague to introduce herself.
Yes, go ahead, Dr. Marcella.
Thank you. And I'm not doctored yet. Thank you so much, Dr. Green and Dr. Navarro. It's so wonderful to sit and Zoom alongside some giants in this work. My name is Marcella Anthony. I'm Assistant Director of Outreach, Recruitment, and Engagement in the Office of Diversity and Medical Education. I've been with Stanford Medicine and with this team for about 13 years. And most of the work that I do is specific to the early pathway. So engaging with undergraduate students, primarily high school students on a variable basis, but not as much. Really, most of my work is around undergraduate student development and creating more seamless pathways to careers as physicians. So I'll tell you a little about Stanford Medicine. I know that you all probably know the name, but our institution focuses on innovation, discovery, and an approach toward patient care, toward research, toward innovation and education with a specific focus on diversity and innovation. Many of our programs, including our summer pre-medical program, we've had for a long time, since about 1997, with a little 3-year break in the middle where we were not funded. And we have lots of success getting students like yourselves through this pathway, largely unscathed, with some bumps and bruises along the way. And it is important, I think, in this time, we've seen a lot of issues that have further underscored for us the disparity in health administration and health outcomes for communities of color. So I don't come to you as a physician, I come to you as an educational doctoral student and as a healthcare consumer, as someone who really cares about my community and have the unique privilege to be able to help infuse some of that caring and consideration and some of those perspectives and narratives from people from my community and people from my family and probably people from your families. So it's a tremendous pleasure. In addition to the work that I do specific to the pathway, I have been part of the admissions process. When Stanford started doing the multiple mini interview, I was the first person to sign up and say, I need to know what this is about because our students will need to know what this is about. And so I've served of the 13 years, 11 of those 13 years as a medical school rater is what we call it, but interviewer, as well as for about 6 years, I chaired a subcommittee of the admissions process that focuses on reviewing diversity candidates. So I don't go into anything halfway. I do really want to make sure that the information that I'm giving, since I was never on the MD pathway, and for my safety and your safety, you don't want me on the MD pathway, but it's really, it's my job to be sure that you have all the tools that you need to be successful and to navigate this process. And success is really dependent on what you see for yourself. It's not my role, in my opinion, to tell you which schools. I can tell you which schools are a good fit based on what you're telling me about how you see your career path. That's the excitement of this work for me. And Dr. Navarro, I'm having a little bit of fangirl experience here being on a panel with you. And I didn't know that part of your story. And this is a quote that I share with our students all the time, because our journeys are very different. Sometimes when you're looking at others, you think, geez, they're getting through this so seamlessly. Why doesn't that happen for me? And for that, I will share my favorite Misty Copeland quote, which is, know that you can start late, look different, be uncertain, and still succeed. And that is equally true for your pathway toward medicine. So I will, there are lots of things that we can talk about. Because I am into student development and really want to learn from all of you, I will give us some time so you can get your questions answered and maybe ask you some questions and interview you while we're having this time together. Thank you.
Well, thank you so much. And you can see what a great panel we have here for you all today. And while you're thinking about your questions, because this is a real opportunity for you, we've brought these experts here for you to have the opportunity to ask them questions. And while you're thinking about and formulating your questions, I'll start by saying to both of you, what's the ideal candidate for UC Davis? Or is there an ideal candidate for UC Davis and an ideal candidate for Stanford? What are those attributes? Each of you can reflect on that.
I'm happy to start. It's definitely hard to pinpoint one thing. As I mentioned, just a general passion for wanting to serve, number one, California communities and wanting to serve underserved populations in particular. But I think what we're really looking for is a cohesive narrative. So number one, it's one thing to say what you'd like to do in medicine, but it's another thing to have some demonstrated experiences showing that you have a longstanding commitment to a particular field or community or a particular interest that ties into medicine. Like your why medicine has to be very important, but your whole application should tell a story. So in general, I think that's what we're looking for is unique things that would contribute to the first year class, because we really are looking at diverse perspectives. I think one of the many benefits of having a very diverse student body is that you learn from your peers. There's just some things you cannot learn in the book about how to take care of patients. You learn that from being exposed to diversity. So when we have diverse individuals, they bring diverse perspectives and they bring diverse solutions to solve problems. So as Dr. Navarro mentioned earlier, we really need to build healthcare leaders. Like there are things in healthcare that clearly need to change, and UCSF has really led kind of the inclusive policies and practices, at least for me in our region, on how we should start to approach kind of some of these things within medical education and in the patient world. So we really that's not going to happen in our lifetime, just to be completely honest. We really need someone picking up the torch and helping to continue this work. And so I think that's what we're looking for as far as like the future of healthcare and how we pick our students. We're looking for strong candidates that can contribute to this overall mission of really improving healthcare overall.
Thank you. And Marcella, what about Stanford?
Yeah, so, people often, so I didn't attend Stanford. And so my standards are a little bit different in terms of thinking about, who's a good fit, and we're not a good fit for everyone. And every medical school, you can probably find things that are in sync with things that you care about and things that are not so much. And so in my experience, the folks who do very well are people who are hungry, who are self-starters, who are willing to question when things are amiss or when they don't understand. Similarly, if you have an interest in making a global impact, so not necessarily, across various countries, but outside of your personal circle of influence, those tend to be the folks who do well and move forward quite quickly in our admissions processes. Similarly, we have a deep commitment to diversity. Our class sizes are pretty small. So 90 essentially is our class size, more or less. But if you can demonstrate a significant and impactful potential for contributing to the diversity of our community, definitely you are a person who should apply. I think sometimes, at least in the pre-med realm, I know it's really difficult because you get a lot of mixed messages. It really is. To Dr. Green's point, there's no one size fits all, and there's no one ideal character or set of characteristics per se, but definitely owning your story is super important. Mm-hmm. No one can tell your story better than you can. Even as a letter writer, generally when I'm talking with individuals, I want to know, what is it about this set of institutions that all fit these certain characteristics? Stanford is a research intensive institution, so you need to know that. Oftentimes pre-meds will think, oh my gosh, they want me to be in a lab and, my lab skills aren't great, or, I really just, I don't like research. Most times, and I'll tell you that was my experience as well. Most times, what you're referring to is basic science research, but there are other kinds of research to be involved in. You can go community-based participatory research, where you're actually involving citizen scientists and citizen health advocates in researching their own communities and better understanding and being advocates. There are lots of ways to explore research. The important thing, if you're looking at Stanford and schools like Stanford, is to emphasize the depth and intensity of the scientific method by applying that to these other forms of research, be it clinical, behavioral, basic science, or some of the others, translational, doesn't matter. So we are a strong, though small community. And so if you're a person who, believe it or not, I'm pretty introverted. I get fearful every time I'm standing in front of a crowd of folks. Zoom has been very helpful for me because it's more like talking to a screen and less, I don't have to count how many people are in the room. But if you're a person who's used to sort of falling in the shadows and, kind of sinking into the walls, it's going to be hard to do that at schools like Stanford. People are doing lots of really amazing things and contributing to science and advances in ways that are almost unfathomable. And I think that's true at all of our institutions. Another challenge for folks tends to be there are lots of options. So the better you know yourself, or better you have a process about understanding how to better own your physician identity, your physician scientist identity, the less you will struggle. The more you know yourself as a learner, the easier it is to reach out. Our students tend to want to maximize their experience in every way possible. So making use of our learning strategists, for example, it's not because necessarily they're not doing well in classes, but they're trying to figure out, how can I get as efficient as I can about this particular coursework so I can go and do my other side projects? And believe it or not, people do actually also have side projects in medical school. So those are some of the things that we look for that are admirable. Certainly, Dr. Green's comment about the consistency in telling your story is also important. Saying that you want to do something and actually providing evidence are two different things. And at the point that you're applying to medical school, we want to have some sense that you've had that exploratory process in a way that adds value to your words when you're saying, this is what I care about and this is the impact that I would like to make.
Excellent. Thank you so much. I'll just add a few additional comments as it relates to UC San Francisco, and very much consistent with what others have said about the kind of candidate and owning your story and describing the strength and the lessons that you've learned from the various things that have happened to you or that you've encountered along the way. That really helps to really define what your story is and recognize that you're looking for an institution that's going to fit with you and really help to mold you into the type of physician and caregiver that you hope to be. So as a public institution, we take our public mission very seriously at UCSF, and we too are known as a research intensive organization, but we're also a community intensive organization is how I like to describe it. We're, in the top 5 for our primary care, but also for our specialty care. We're always in the top 5 for our research, but we're looking for healthcare leaders, somebody who's going to come in and really understand the full spectrum of what it is to be a physician and understand how that plays out across the healthcare world, be it policy, certainly in novel ways to be more inclusive and to dismantle some of the racism that exists in the delivery of healthcare, the access of healthcare. How does homelessness fit into the challenges of being a healthy individual, and what are the ways in which as physicians, we can influence those other aspects of the disparities that we see within health and within healthcare. We have 73% of our students are California residents, but many of them will attend their undergraduate years outside of the state of California. We want folks to come home to California and to UCSF for their medical school years. We have a program called PRIME. Our PRIME program at UCSF is focused on the urban underserved. It's a primary program where we have our students, a subset of our students, about 50% of our students who apply to our medical school also apply to our PRIME program in medical education for the urban underserved. And those individuals will spend an extra year getting a master's in public health. And about 75% of our students will do an extra year getting a master's in science or a master's in public health. But our PRIME students are really focused on the underserved urban populations that exist in San Francisco and what's the role of the physician in those areas. And that has been quite a popular program that has really helped to drive both changes to the overall curriculum. Again, we're looking at changing the way we train all physicians. We feel that all physicians need to understand how racism is embedded within medicine. And so our PRIME program, which is now over a decade old, has really helped to drive and been the fuel for the kind of rapid changes we're seeing in our curriculum now, looking at every aspect of things we do to train doctors, from the standardized patients, the language, how does race, enter into how we're looking at lab results and things of that sort. Sort of across the spectrum, we're really challenging the status quo at UCSF. And so we're looking at people who, like others have said, have demonstrated what their passions are by their activities, but are really eager and curious and willing to take that next step and help us to kind of really overhaul medicine into the future. So that's a candidate. And they, we have such a wide variety of diversity of our student population. Most of them, majority have not come directly from undergraduate. They have these lived experiences. We have some who are lawyers or already have their PhDs or have worked in the business world and have real innovative minds about technology and medicine, big data and medicine. So that's the sort of wonderful nature of the kinds of interactions you get from your colleagues across the medical school. And so the admissions office is really looking at that composition. And as Dr. Green has said, how that influences other learners. Really, the peer learning is so important as well. So those are all kind of the things that we're looking for at UCSF. Have there been any questions? You can put your questions in the chat. Alternatively, you can raise your hands if you have any specific questions. And while you're doing so, I will ask about COVID and how has that changed the admissions practices. Dr. Green, you want to share what's happened at Davis as a result of the pandemic? How's it impacted your admissions process?
Wow. So I'm on several national work groups with the AAMC. I believe y'all know what that is because I think you've had a few admissions talks. And I can tell you that we as a community, medical education community, understand that there has been like severe increased inequities due to the pandemic. And I wouldn't say just as hard, but I would say that medical schools had some challenges adjusting to the pandemic as well, moving curriculum completely online for a time, very quickly moving all of our admissions processes from a very in-person process to a completely virtual process. So that has been challenging for schools as well. And I say all that to say, I think at UC Davis, we've really worked to provide realistic insight and additional training to people who review applications. So our admissions committees, every person that touches an application, I'm a person who is responsible for actually writing policy related to admissions and making sure we have a fair, equitable process and making sure that everyone has the trainings completed and they are well-versed in the way we review applications before they even look at an application. So I think those efforts have really increased. It's hard to measure at this point, right? Because we are still in it, right? We're still in it and still, I think, trying to figure things out. I think it's settled down a bit, but things had to happen really quickly. So number one, all of our admissions committee members, this is even before the pandemic, everybody before they touch an application must take an implicit bias mitigation training, like period. Like you won't be routed anything until that's taken, and it happens every single year. If you've been serving on an admissions committee for 13 years, then you're going to take it 13 times. So that is a requirement every single cycle before you touch anything. And in those trainings, we also include any updates that's relevant to that particular cycle. So we do incorporate insight on the challenges applicants have had getting experiences that help their application. The expectations we had before for applicants on their experiences has changed a little bit because we have to be flexible because people haven't had access to those things. And we know that our disadvantaged applicants who are largely from a statistical perspective overlapping as URM students, they've had even less access to things during the pandemic. So we know these things. Many admissions committees expect you to have longitudinal activities, meaning activities over time, right? Like we know that things came to an abrupt halt and you weren't able to do those things or even get those activities starting spring 2020. We know that there were Mcat cancellations and reschedules due to COVID in your family, yourself. Even when some of the protests were happening, they were canceling Mcats. So we have a policy around when Mcats have a forced reschedule or cancellation. So we've allowed later Mcats, but also tried to provide realistic expectations to applicants about when your application is reviewed, because right, everything's on this huge long timeline. So I think there's a lot of things. I think now where we're at in the pandemic, it's been more case by case situation. So the training and everything is still happening. But I say this long explanation to say that I think medical schools are more open to being flexible, and it doesn't hurt to reach out. If you have a question or you have a late MCAT or a specific thing happen, reach out to the admissions offices and see what can be done. Because we know that there are challenges. And I will say that although we reviewed exceptions often before, I think exceptions now in this current state are more likely to be approved, and we're more flexible in trying to work with applicants because we know the challenges that you all are facing.
And Marcella?
I'd say similarly, we also have required the implicit bias training for anyone who's a part of the admissions process, as well as file reviewer training, specifically interviewer training as well. We've seen a couple iterations in terms of accommodations with regard to COVID. In the early stages of the pandemic, that included MCAT optional submissions for the same reasons that Dr. Green mentioned. There were also a fair amount of issues with students getting experiences. And what we learned over time, and part of that I think is due to some of the outreach that we've all conducted as individual medical schools and through our different affiliations with our medical school partners, is to communicate with students about other options and opportunities that may be available that are not necessarily things like shadowing a physician. And so we've seen the evolution of the resilience of all of you and your peers to be creative about ways to stay involved and to continue to get that experience that is added value and demonstrated commitment to the health and wellness of society in some of the things that you've participated in, whether that was creating PPE early on. Remember back in the day when we couldn't get any masks, whether that was creating and distributing PPE, actually gathering and fundraising. We've seen a lot of really wonderful stories of folks who are able to persist and actually make experiences happen. Now I'm saying that, but if you've looked at the AAMC, any of the content, especially around holistic review, you've looked at the experiences, attributes, and metrics model. And there's this wonderful concept called distance traveled. we like to say that we coined it. I can't say for certain that we did or didn't. Here's the thing. I've only been with these folks for 13 years. But I can say the holistic review process is not something that's new, especially in California. Each of our institutions really does try to look at the individual applicant and get a sense, given this environment, these experiences, these limitations that this candidate has talked about, what reasonably should we be expecting? And that's not, we can't do that in a way that's a blanket statement toward all candidates. So there was and remains that flexibility even pre-COVID to look at your background, to look at what resources you have available to you. Did you make the best use of all of the resources available to you, given the constraints and given the opportunities that you have? We also underwent issues with virtual processes, so interviews for sure. We're still in a virtual interview process, more or less, and we're emerging from that. The Mcat optional language is no longer part of our admissions process, so you all have to know that moving forward. All indications are that we are turning a corner, I think, with this pandemic. And so you can expect that there will be some really useful changes in terms of how our file reviewers and other folks who are connected with the admissions process are being constantly coached now to think about candidates and their experiences when they're making evaluations. We've also built in several measures, and this is prior to pandemic, but I think really particularly salient amidst the pandemic, is to have more sets of eyes on applications. And that's actually helpful just in any quality process. If you have one person reviewing, eventually, over time, with hundreds of applications, that person is going to experience fatigue. So having other folks to jump in and be able to review those applications has really helped us in terms of upholding our commitment to diversity, but also being cognizant of the challenges that have presented themselves to a lot of our candidates, specifically during COVID.
Excellent, thank you both. We have from our chat a couple of related questions, and then I see hands raised. So we're gonna get to all of your questions. This first one has to do with public health. The one question was specifically looking at applicants who come in with a master's in public health. And to expand that, the question was, how do you best articulate your interest in public health and health policy in your medical school application without looking as though you should just be going and maybe getting a PhD in public health as opposed to the implementation of care through a public health lens? So those are related. If one of you want to tackle that particular question, whoever would like to. Charlotte?
I was going to say, go ahead, Marcella.
Thanks. And so, it's absolutely wonderful when we have individuals coming in. First of all, to piggyback Dr. Navarro's comment specifically about individuals coming with prior experience. That non-traditional is traditional, essentially, on the Stanford campus. So it's unusual to have someone do their 4 years of undergrad, apply, and matriculate at Stanford Medicine. It's unusual. Folks have gone and done a variety of things, and public health is still the most common MD complement in terms of credentials that our medical students pursue. So you need to know that. We actually, in our secondary, allow you to indicate specific areas of interest. So there is a health policy focus. There's also a community health focus. A number of our medical students are doing work with our Center for Population Health Sciences. So one is sort of this declaration that you're making about where your interest lies. And the second part you have to remember is going to come through in your experiences. So we'll be looking at those breadcrumbs that actually point to your interest as a care provider in a public health setting, or an individual who's interested in public health policy, through hopefully some of the initial work that you were able to engage in during your undergraduate experience.
Thank you for that. I'm going to ask Mariah, she's been waiting. Mariah, you want to ask your question?
Sure. Thank you all for being here. I think this has been really helpful. My question has to do with the application cycle and interviews. So I know like since COVID has happened, a lot of the interviews have been virtual. In terms of like the next couple of years for the interview cycle process, do you guys foresee like them continuing to be online or going back in person?
I'm happy to start. So it will definitely be virtual this upcoming cycle. The admissions committee is still deciding if we'd like to keep it virtual. We are leaning towards yes, just because of the cost that it costs applicants to travel to in-person interviews. So what we're hoping to do is keep our interviews virtual and then have more on-site second look or revisit days throughout the cycle. Is hopefully the long-term plan, but it's still kind of in flux depending on what does happen with the pandemic and cases. And actually we have a survey going out to current applicants on what their preference is as far as being able to have access to see the school, and how they feel they perform in a virtual versus an in-person environment. So still more to come on that, but there's been no final decision, but I think we're leaning towards virtual permanently.
Similarly, I know there are a lot of benefits to remaining in the virtual environment. Certainly cost is one of them, trying to reduce that. So all of our applicants have more equitable access to interview dates and times. I have my opinions, I think, about the in-person versus virtual interviews. However, there have been a couple different iterations. So in the first iteration of the virtual interview, we were using an interview process, a product essentially, that I personally did not find super helpful in teasing out those nuances, not being able to engage back and forth with the candidate. Moving forward and using more of the tools that we're accustomed to, Zoom type tools where we can have synchronous interviews. I think if our institutions do move forward, that's certainly the way to go for us to be able to engage with candidates in order to replicate what would happen in an in-person interview. I know it's a little bit hectic for all of you as well. I actually did a virtual interview for a fellowship, and it was nerve-wracking, absolutely nerve-wracking. So I know what those challenges are. But keep in mind, medical schools are not trying to actively keep you out. We are looking for ways to better understand your fit, what contributions you make to community. And that can come through in interviews. Whatever we decide, I will say that many of us will be committing to putting more opportunities out there for you all to do mock interviews, so you build that comfort level. The more you do it, the more comfortable hopefully it becomes for you.
Excellent. Thank you for that excellent question, Mariah.
You guys
have your hand raised for a question.
Hi, my name is Kirsten. Thank you guys all for being here. First of all, I'm just really excited to hear all you guys speak because I am actually applying this cycle, and you guys have addressed many things that I have been struggling with as I put my application together. So I actually asked the question in regards to public health because I've been struggling with, I feel like, getting caught up in looking at how the admissions might perceive some things that I stated in my personal statement. I have a really strong interest in like preventative medicine and public health as well. And I've been getting bogged down in the details of feeling like, oh, well, what if they look at this as me like not needing to be a physician to do like certain things like at a systemic level, because I know it's like physicians don't necessarily like look at the systemic level of trying to dismantle some of like the things that we've currently seen, or at least that's some of the commentary that I've received back, like, oh, you might not want to say this because it could be looked at like you don't need to go into medicine, if I'm mentioning stuff about like public health that I've like that has impacted my decision to going into medicine, I would say. So I don't know. I just wanted to get more feedback if that might be stuff that maybe I should just stick in my experience section to put a glimpse of like the public health interest and not really talk about it in the personal statement, or if I could intertwine both.
I can start and then others can chime in. I can just say that at UCSF, it would be looked upon favorably because in fact, particularly in academic medicine, you're looking at population-based health and how we can actually improve the health of a population. And certainly preventative medicine is an aspect of that. And so we, again, want you to tell your unique story about how you came to your interest in preventative medicine, in the health of population of the communities, and how then has that really drawn you into medicine as a career. It may be a path that leads you to want to do more around getting a master's so that you understand the data and how to utilize those data to implement practice changes and policy changes that are going to, therefore further impact communities. So I think it's a plus.
Really quickly, I agree. It would be a plus for our institution as well. I want to just touch on for a second professional responsibility. I think this was mentioned earlier, but regardless of what people think, right, there is a stigma or an assumption that comes with that white coat. People assume that you have a certain knowledge base, many things they assume, right, that you have education, right, and it is their responsibility of physicians to use what comes with that white coat for good, right, hopefully. So there's a professional responsibility to advocate, to stay abreast of your field, to make sure you are educating your patients appropriately, blah, blah, blah. So I say all that to say for us, it would be a plus because I think that interest, so I'm not sure where you're getting like the advice that it's not a plus, but I think again, that interest always adds to medicine. So maybe they're saying the way you're explaining it in your personal statement is not fully helping people understand the why medicine piece. So maybe tying it to how you'd like to use it, to specifically how you'd like to use being a physician and your background or interest in public health to like connect with direct patient outcomes or certain communities or a certain illness that you really are interested in. So maybe it's not tying together for the reader, and maybe that's what that person is trying to say. So I think maybe ask for more specifics about that advice. Or I always say you should not be doing this process by yourself. Like people who read applications and who work with people to get them in medical schools should be involved in this process. Like your mom's probably gonna be like, yes, great personal statement, but you really need people who do this because they know what a successful application looks like and what a not successful application looks like. So just maybe the way you're wording it is the cause for the advice, perhaps.
Okay, thank you.
Same deal for Stanford. And so, everything that you're saying, it's only added value. We don't get to decide again, it's really, most admissions committees are looking for when you say, I have an interest in doing this specific thing. Do we have the capacity within our institution to provide those skills and developmental opportunities so that you are crafting your physician pathway in the way that you see yourself? And public health is an easy, as I mentioned, many of us have, all of our institutions that are represented here have specific centers, specific affiliations that allow you to do that work. I had a similar, I'm so glad that Dr. Green mentioned that about, the triangulation process. Talk to people that are affiliated with these processes. I do a lot of work with community college students, and a lot of community college students will tell me, well, my advisor said that, I shouldn't be saying this. And this isn't a dig on the person, right? This is really about you getting what you need and getting accurate, relevant, and timely information. how many candidates has that advisor worked with and actually gotten into medical school? What kind of affiliations do they have with the medical schools that they're giving you advice about? People mean well. It's not that they're trying to intentionally set you up. They're actually in many ways trying to be as conservative as possible because they believe that's going to get you in. So just beware, and I think, continue to ask questions about, how I think that it's really good advice is if this is a person who's giving you feedback specifically on your application, to dig deeper and ask for more details. What would make this sound more like a person who's on the pathway to becoming a physician, but has an interest in looking at public health in this context? How can I better describe this in a way that suits it? And if this is a person who's not actually giving that feedback, maybe take it to the individual that you're consulting with or individuals specific to your application. But I don't think any of our institutions would look at someone who's, we offer all sorts of degree combinations, MD, MPH, MD, JD. There are a variety of things that you can do, and it really is about you having that vision about how you want to enact change in healthcare.
Okay, thank you. That was really helpful. Thank you all for answering.
Great question. Thank you. Kind of a follow-up, Marcelo. There's a question from Antonio Nunez asking about how do we find the good extracurriculars, and is there a checklist, for example, 25 hours of shadowing, 100 hours of clinical experience, et cetera? Can you address that?
Okay, I'm cringing a little, and it's just because of my training. Probably Dr. Green and Dr. Navarro felt a little twinge, like an eye twitch. We're not big fans of the checklist, and part of medicine is it's a different standard. It's a different standard than almost in a society where we are increasingly having more exposures to instant gratification. Medicine is still the old school. You have to put in the work. So that checklist, you have to sort of throw that out. Anyone who's telling you, do this amount of hours, and then, okay, you're all done with that and go to the next. There are certain thresholds that you should really be thinking about. One, in terms of your capacity. And this is part of the reason why we don't have a number of folks applying right out of their 4-year experience to med school and matriculating at Stanford, is because one, it takes time to do the exploration, to really feel comfortable in your pre-professional skin as someone who's going to go about this pathway. You have to put in the time and you have to put in the effort. If you think about the things that you love to do in your free time, does someone have to tell you, hey, you're really not committed to your ballet dancing, right? You have to put in the time. If you've done any sort of training. I use Taekwondo because my family and I studied Taekwondo. When I first started, I hated it. I hated standing in positions. I hated holding my arms up. They would get tired. At some point, going through those different forms, when I sat into a stance, I felt right. It was right. This is what I'm supposed to be doing. I didn't actually need an instructor to tell me that. And similarly, for these experiences, you want to think about, how am I scaffolding upon these different experiences, service, shadowing, in a way that informs how I want to represent myself. When someone says, how much shadowing is enough shadowing, for example, some of the advice I give is, one, here's my perspective, and this is mine personally. I want to be sure that when you walk into a hospital for the first time and you smell feces, or someone's actually coming into the ER and they're bleeding, and you smell the iron in the blood, that you're not going to fall out, that you don't become a patient because you've had a head injury, because you've never had that experience. Now, when we talk about things like service in your co-curricular opportunities. Those are all things that you choose. So you ought to be able to show consistency in the types of co-curricular opportunities that you pursue. And that means, you know, it may not be possible for you to continue to volunteer, for example, in an after-school program. But if you're committed to working with youth and you're concerned about the health outcomes of at-risk youth in your community, there might be another way to continue that work in a way that is still true to your experience. So I don't tend to go with numbers or like, you did this, now check off. I usually ask, what are the insights that you got from that experience? Can they demonstrate depth and commitment? And can you talk about them in ways that are added value that demonstrate that you can assess what's happening in a community? We all know that, you know, things are happening, or, you know, to a specific population or to a specific kind of person in our community or society. So I know that's not super helpful, but I'll turn it over to Dr. Green, who might have more specific advice for you.
Dr. Navarro, did you want to chime in first? I saw you.
No, go ahead. Go ahead.
Yeah, I everything Marcella said is like spot on. I think it's like she said, if you're going to do ballet or taekwondo or be a professional basketball player, you can't just show up at the court and say, yes, I'm in this thing. That's not how this works. So you need to have the activities and the experiences that, number one, let us know you've been exposed and you really want to do this. This is a lifelong learning profession. You will never stop taking tests. You will never stop learning. Like, that's what you've signed up for. There are literally board exams like throughout your whole career. So if you really want to do this, we want to make sure that you understand what you're signing up for. So that's the number one thing, is that because the journey is so long, we want to make sure that you've had some exposure. And as mentioned, Marcella already mentioned this, but when you step into a clinical space, you need to adapt and adjust to that space. People are getting bad news. People are dying. They're expiring in this space. Like, you're going to see that as a physician, and you need to have some emotional intelligence to be able to handle how to navigate that, to give bad news to a family. Like, there are things that are going to happen that require some emotional maturity that we don't want you to start trying to dive into in your first year of medical school. You need to come exposed, maybe not fully equipped. We'll help you dive into it more, but you need to come exposed to what the realities of medicine can be. So that's the only thing I wanted to add, but everything Marcella said was really spot on. We definitely don't do the checkbox thing. Again, we want you to have some exposure to things like, for instance, we're not a heavy research school, but we want you to have done some research, because we know you're going to probably need some research to be a competitive residency applicant. And we don't want you trying to figure out how to learn how to do research while you're trying to learn how to be a doctor as well. So although we don't require probably as much research as the other two schools that are represented here on this panel, we do want you to have some. And the checkbox thing, why that doesn't work for us is because, again, it has to make sense. So if you're just saying, I'm going to take any old research and take any old clinical shadowing experience, and that narrative doesn't speak to, number one, why medicine or what your career goals are, then that's simply what it is, a checkbox that doesn't make any sense to us. And it's going to immediately make the admissions committee say, still don't understand why this person wants to do medicine. That's what you don't want. If they're trying to figure it out, then I have 7,800 applications this year, and I have spots for 136. That's going to be an easy no, because your application, the math ain't mathin', as the children say. So make it math, make it make sense.
Excellent, excellent advice. Iana, you have a question.
Yes, I do. My question was about letters of recommendation and kind of going back to this idea about the checklist. So with applicants who do have letters of recommendation from a physician versus those who maybe have letters of recommendation from other, like not a physician, I was just wondering, how do each school look at that or value the differences? I guess my question more is it about the value of the letter, or does the person who wrote the letter also matter as far as needing to get a letter from a physician or not?
Dr. Green, start.
Sure. So for us, we do like to have a clinical letter. Could be from a physician, most oftentimes it is. And then we do like to have like an academic letter, because we're trying to really, letters are really that opportunity for someone to vouch for you and say, this person can do this. This person is committed to medicine. I've known them for this long. I know how badly they want this. And I think based on what I know, they'd be an excellent physician. And academically, this person is a hard worker, you know, top whatever 5% of hard workers I've ever had in my class academically in this basic science class. So that it's really an opportunity to vouch for an applicant. With that being said, I'd rather have a strong letter than a generic letter from a physician or professor. So if you worked at a nonprofit for 3 years and the director or your direct supervisor writes you an incredible letter that speaks to the things that I just mentioned, then that's also pretty impactful. What you don't want, and this is why I say relationships are so important, especially as you're going through undergrad and taking classes with your like core science faculty. If you have a connection or you think you want somebody to be a letter writer, you should be staying engaged with them. You need to be sending them like happy holidays. I'm still gonna be applying to medical school, blah, blah, blah. Hope your family's well. You need to be using checkpoints to make sure you're staying engaged. They remember who you are. So they actually can write you a good letter when it comes time, right? Because it might be 2 years later when you're ready to apply. So you want to make sure that you're staying engaged with your letter writer, potential letter writers, you're letting them know what your intentions are in applying to medical school, and you're providing a timeline. So again, stronger letters are better, because the worst thing is like you get a letter from a physician, but it's like wrong pronouns. They don't really know you. It's a copy and paste. Somebody else's name is embedded in there somewhere. Like that is the worst. It's like this person didn't even care enough about this applicant to write a strong letter for them. So that actually looks worse. So again, it's a longer answer than just letter from this person or letter from this person. It's like, did you have the sustainable engagement where this person truly is vouching for you in this field?
Anything else to add, Marcella?
No, Dr. Green said it all. That's exactly, yep.
Excellent question.
Yep. A great question.
Like a lot of the fears that I had and concerns that I have, because I do feel like I have stronger letters from other people, and I'm like, should I just, try to make a fake relationship, which doesn't feel comfortable like in my heart. So thank you so much. That answered it perfectly.
Excellent. Ursa's iPhone. Your hand raised. Please correct me on my pronunciation.
Ursa, yes, that's correct. My question was, is there anything that would make our application just be thrown out immediately and not evaluated? Like a seeing our application and it just immediately not looked at and filtered out.
Great question.
Yeah, I can tell you on this on the Stanford campus, every application gets reviewed. I would probably encourage you to focus on what's going to make my application be an absolute rather than what's going to make it be thrown out. There are some technical considerations that are outside of the scope of anything that I do with regard to the admissions process, where a candidate will receive an instant rejection. Those are very unique. And so really not even worth mentioning, in my opinion, because many of you are not going to fall into that category. It's a much better use of your time. There's so much to this process to really think about, how do I hit the mark to be sure I'm representing myself in the best way possible and giving this reader and admissions committee the best understanding of who I am as a candidate and why I would be a good fit for this institution.
Thank you.
Thank you. Great question. Christabel.
Hi, thank you for being here. I'm also applying this cycle, and joining this call has been like a blessing because I'm getting a lot of my questions answered. So thank you so much for your time. I'm asking a follow-up question to the letter of recommendation. I've heard from a couple of people that your meaningful statement, your experiences that you explain as meaningful, and the various activities that I may go ahead and state in my personal statement should have letters of recommendation to back that up. And I wasn't sure how important that was or critical it was, like, because can I go ahead and talk about an experience as meaningful without having a letter of recommendation to support that, or it's something you would like to see?
Yeah, I think it is something the admissions committee wants to see. if you say something's meaningful and it's the whole reason why you chose medicine, but you don't have a letter to, again, you're trying to tell a whole story with your application. If you don't have a letter to kind of corroborate that notion, then it does kind of look bad. I mean, I sit in every single admissions committee meeting and I've heard them say that, like, you're saying this is important, but where's the letter? So I think that is kind of one of those hidden curriculum, unwritten things, is that admissions committee do really look at that.
You have to remember, folks are reading a lot of applications. The last thing you want is for someone to fill in gaps of your story for you, because you don't know if that's going to be added value or if it's really going to take away from your experience. And so can't say it enough. If you're going to list it as a significant experience, as one of your 3 most meaningful, please have a letter with it, because it is a red flag. People are automatically going to go to something must be wrong, not, well, this was an oversight, or, or the student wasn't counseled, which sometimes happens. Please make sure you have a letter accompanying it. Because again, if there are thousands or tens of thousands of applications, what's going to be the easier road?
That's great.
Thank you so much. I didn't know that. I just heard it. So I'm glad I asked. Thank you.
To quote Dr. Green, make it math, right? Make it make sense. So they don't have questions. It's perfect. Thank you for that question. Mariah? You have a question?
I have one more question. I know like 4th years make a big deal of match day, and it's like a huge, deal across the nation every year. So I'm curious, what kinds of unique resources or programs does your school offer that helps medical students succeed when applying to residencies?
I'm happy to start that. So we have an academic coaching program that is specifically focused on your career exploration and specifically the match. So, and when you come in as a first-year student, you're connected with an academic coach, and we have like small group work. So your coach will have 8 students in your first-year class, and you actually have that coach throughout the 4 years. So by the time you get to your 3rd year, like your intro to 3rd year, your academic coach will start working with you more to talk about. So you should have already had conversations, but to talk about what are your specialty options that you're really thinking of. So then they can connect you with actually specialty advisors that we have in each department. So these are like paid physicians that their job is to make you a competitive applicant for that specialty that you're interested in. And then they work with you, like basically handhold you through the ERAS process, which is the application process for residency. That's typically due, I think, September 15-ish of your 3rd year, or no, of your 4th year. And then you participate in the match process from there. And then there's like this whole ranking process. There's a lot of algorithms, 1s and 0s types of thing. But essentially that's what it is. There's a support program that you would work with the same person all 4 years to do career exploration and then actually apply. And that includes connecting you with shadowing opportunities, helping you apply for acting internships or AIs or way rotations. So you can get exposure to even other institutions, especially that specialty you're interested in at other institutions as well.
I would just say at UCSF, it's much the same. Academic coaches from the first year with small groups, career counseling available as you start to develop interest in specific subspecialties, and then senior rotations, but also those visiting elective rotations or opportunities that many of our institutions offer with scholarships, particularly for underrepresented minority students. And I urge my students, especially in some of the more competitive specialties, to, if you're an outstanding clinician and maybe your numbers aren't that outstanding as it relates to the board scores, do a visiting rotation so they can see your excellence. And in most circumstances, then you're given an opportunity to interview in those locations as well. So that's been, I think, something over the course of the last several years that's really allowed our underrepresented students to shine when they have these opportunities to do the visiting rotations. It's been a particular focus of UCSF that we increase the diversity of those students in when we match. When I started my work on this, we were about 30% of our students in medical school were underrepresented minorities, and it dropped to 15% at the residency and 7% at the faculty. We're now 40% of our students are underrepresented in medicine, 34% of our residents in the most recent match underrepresented in medicine, and now about 11% of our faculty. So we are specifically focused on diversifying that full pathway to academics. Ultimately, we want to diversify our faculty, but
lots of support along the way. And part of the ways in which our medical schools, we judge ourselves is our ability to see that our graduates match in the residencies of their choice. So that's something that we really focus on.
Same's true for Stanford. So I think our numbers are in the past 3 years have been 95% of our students match in their top 3 choices in terms of residency. Similarly, we have advising deans that are assigned when students come on board. That's your person, that's your home base. They help you. And literally what Dr. Green said is absolutely true. You are handheld through that process and advised throughout the way. I also wanted to point out that Stanford has a wonderful program called SCORE, which is an early residency opportunity, exposure opportunity. So you do get to do a rotation. This is a specific diversity effort. It's not just about, it wasn't offered haphazardly. So if you do wind up at other medical schools and, you want to come back to a specific institution, look for those programs and opportunities to come back. And those away rotations are a really great way to be sure that it's going to be a good fit and to understand the climate and environment that you're wishing to return to.
Excellent. Thank you so much. Thank you for the question. We have time for maybe one more question. And I'll ask Dana to ask her question, and we'll try to give you a quick answer.
Hi, everyone. Hi. Thank you for all of your answers so far. I'm actually gonna ask a question that was asked in the chat and I thought was very intuitive. So the question was, are there any aspects of your application that make you more likely to earn a full or partial scholarship for medical school? Or are there even opportunities for scholarships at your respective institutions?
We try to meet 100% of need. Primarily our scholarships are need-based scholarships, and we had a big fundraising campaign to be able to meet 100% of the needs of all of our learners. The Prime program includes some additional scholarships that make that extra year completely free to those who are accepted through that program. My quick answer. So quickly, Charlene and Marcella.
Yeah, ours are needs basis based on an algorithm, basically. We actually have a score that measures what Marcella mentioned earlier, the distance travel that's taken from your Mcat application. And that's how we decipher need. And then we basically plot people on with our algorithm to award scholarships. And it's similar to Dr. Navarro, we have a bunch of different mission focused program or scholarly pathway programs that have certain amounts of money associated with it as well.
Same for Stanford. We have a lot of need-based programs where actually we did receive a transformative gift. So a number of medical students do receive a full ride. We also, one of the things that is unique is we have the Knight Hennessy Scholars Program, which is a fully funded program for all graduate students. So there are actually graduate students at each of our schools that are selected to be part of this program. It is based on your leadership capacity and your leadership potential. Outside of that, there are lots of unique ways. I just want to point out to all of you, it's a medical school's job to help you finance your medical education. What that mix looks like is going to be different from institution to institution. Your first goal is getting in and then looking at your packages. I can't express that enough. Don't discount yourself from any opportunity. Apply first, get in, and then what was the saying, Dr. Green? Make the math work. Make the math. I put it in the chat.
Math match.
Make the math match.
Thank you, Dana, for that great question. Thank all of you for your questions, your participation, your engagement with us here today. We're here to support you. You're the future of medicine, and we want to see you be successful. Please join me in thanking this outstanding panelist, our outstanding panelists, Marcella Anthony from Stanford and Dr. Charlene Green from UC Davis. We really appreciate your skill, expertise, and the work you do every day to help our students succeed and to help the profession of medicine. It's a privilege to be here with all of you. Thank you for joining us for this program. Stephanie, do you have any additional
Yes, I just have one thing. This was amazing, and I think everybody could give you guys a big round of a clap because you answered so many questions. There are people that have sent me in the chat. Oh my God, this is what I needed to know. So thank you, all three of you. You were wonderful, and I think we're going to repeat this panel for sure next year. So thank you again. With that said, I just have one question. If there's any emails or any links to anything that you guys can provide, would you please send them to me or put them in the chat and I can send them out. If you think about them later on, just send them to me. If you can put them in the chat, they can see them. And then that would be really great. Okay. And then the last thing for the students, I think we captured this, but I just want to make sure if I missed anybody because Dr. McDonald called in. So the students who said that they were interested in the internship, I have Mariah Williams, Jessica Rivera, Geraldo Magna, Josie Martinez, Antonio Nuez, Oxamara Rodriguez, Savannah Jasper, Panaya Parmora, Morty, I'm not good at these names, please, I'm sorry, Merity, Anyana, Taylor Carr, Penelope Reynoso, Alexis, Erica Lang, Emmanuel Yilma, and Shinlin Love Johnson. So is there anybody that I missed? You need to send me something right away because I'm going to be sending this list over to him so that when you do apply, he will know that because there are other people applying, he will know that you guys came from DOB, Doctors on Board, okay? So if I missed anybody, let me know. Thank you, guys. We have lunch now until what, 1 o'clock, Tracy, Carolyn?
We have lunch until 12:30.
No.
It's already 12:30.
We're going to take lunch until 1 o'clock.
1 o'clock. Okay. All right. I'll see you guys at 1 o'clock. Again, send me your names if there's anything I missed. Thank you and see you soon. I got it. Hi, everybody. Okay, we're ready to start our next session, which we have decided this is new. This is a new workshop that we have not done before. And the reason we are doing Communications 101 virtual and email etiquette is because one, we noticed a number of you in your applications, the whole process, there were lots of glitches, and we want to just kind of remind you because when you apply to medical school, it could, there could be some things that you didn't do or could have done easily, and it could make all the world of difference in your being accepted and your proceeding in your journey to become doctors. So with that said, I would suggest that, again, you take notes. And then after that, I want to go over a little bit after this is over about the parent workshop with everybody, okay? So this workshop, there's 4 of us on it, and each panelist will have, each panelist will have a chance to chime in if they want to add something. And if you guys have a question, just put it in the chat and we'll try to pick it up, okay? So again, this is called Communications 101, and it's dealing with virtual and internet or email etiquette. And the first thing is to make sure that the address for your email is professional. We have seen nicknames, inappropriate titles, part of a name that was so complicated. So just sometimes what may be the best thing is, as you're applying for medical school or anything else as serious, is to set up a separate Gmail account and just put that be the one that all of your serious business can go to. So, because I mean, there were kids that put wrong numbers in their email. and then they didn't know why they didn't get the email. It's a lot of work to go back and do this, okay? So we just wanted to make sure that you highlight, or they left out an alphabet. We don't retype your address, your email. It's generated through the system, and they generate a database. So we don't make mistakes, because whatever you put down is what we send back. So we just want to make sure that you're all alert to that, okay? If you're applying to an email, be sure to add your name. I can't tell you how many emails we received that I didn't know who they were from. I had to guess. So what we would suggest, and we're going to give you this document later on, is that if you set up a separate email, you put your name, you want to sort of tell your own story in your email. It's very powerful. So we have some suggestions. For example, one young man, he put his name. He said he was from the University of Berkeley, University of California, Berkeley. He even put that he was a BS bioengineering and business administration. And then he put his telephone number. And then he put his email, even though it's in the address, and he put his LinkedIn address. Another one added the same thing, but he added sort of a mantra. And then another young lady who did a great job, and she's working with us, she added her name. She was a project coordinator. She added the organization that she was working with, that she's a postbac student in the school in a year, and then that she was a candidate for medical school in that particular year, and her cell phone number. So that it's easy for the person that you're trying to get something from, that they can get back to you. Because everybody, sometimes, even in my case, it's easy for me to pick up the phone and just leave a message, because I don't know it's just easier sometimes. And what you want to do is to build your network and build a group of people that are supporting you, okay? The other thing is, know that the difference between reply and reply to all. I know this all sounds very simple, but some people reply to all, and sometimes you don't need to do that. Sometimes the message is a thank you to that person, even though they may have copied. In my case, I may send you an email, right? And then I may copy my board, because the board may want to see that email that so-and-so is saying thank you, and they are a wonderful student. And, maybe if something comes up based on this student, but they don't necessarily need to see your thank you, Miss Bella, okay? They just sort of kind of figure out when to reply to all and when to reply to just to the person. It's very important, okay? Formatting and use paragraphs. Some people wrote the whole thing. They never had a break except a period. So it was like 16 sentences. That's too hard to read in an email. So understand how to make breaks and paragraphs in your emails, okay? And for most of all, use appropriate language and grammar. Remember one thing, email is not texting, okay? So we may do it amongst our friends, but when you're trying to professionally apply for a medical school or internship, or if someone sends an email to Dr. McDonald, don't put you are, say you are, or can you, or, spell it out so that it's really, really clear and understandable, and it's good grammar, particularly, okay? And those were my major tips. Are there any questions? Okay. All right, Dana, I think, okay. So Dana, she is one of our project coordinators. Dana has worked with PMF. She's a postbac student at UC Davis, right? And she has a few tips that she's noticed, because she's dealt with these files as well as receiving your emails as well. Okay, Dana, please join us.
Yes. So I'll start off with actually adding on to everything that Ms. Bello said, which is, if someone indicates that a message is important or urgent, just make sure that you respond in a timely manner. Usually it'll say important, urgent in the subject line, etc. And then adding on to that, it's
let me just add one thing, Dana.
Yeah.
What is a timely matter to whom? To them or to you?
No, to the sender. So basically as soon as possible, not what you think is a timely manner, like, oh, it's fine if I get back in a day or two. No. So if you see a sender, as soon as you see that email, essentially reply to it. Don't put it off till later. And then on that note, so make sure that you're utilizing subject lines efficiently for yourself as well. So when you're sending an email to somebody and you want, you have an ask or whatever it is, make sure you have a subject line that reflects your email, but also make sure that it's short, straight to the point, just to give the recipient an idea of what the message is regarding. And a lot of people receive hundreds of emails per day. So it also helps, Ms. Bello. So it helps distinguish your message if the person is receiving a bunch of emails. And then sometimes you can also change or update the subject line that you received. So if the original email was general, you're now requesting information about something, you can update the subject line so that the reader responds better. When you're drafting an email to somebody for the first time, or not even for the first time, but when you're drafting an email, make sure you greet your recipient properly and use proper closing statements or sign-offs. It doesn't have to be a whole paragraph about how are you and all that. Just short and sweet again. Just don't go straight into the message without saying hello or well wishes, etc. Especially if it's somebody that you're not familiar with or it's the first time you're reaching out to them. And again, in doing so, keep that professional as well. And then you want to introduce yourself, like, especially again, if it's someone that you have not communicated with before, give some context as to who you are, where you met them, anything really that can help identify you or kind of place who you are, where you are in your journey. And again, important to reiterate that maybe in your sign off as well. If you're trying to set up a meeting with someone, if that's what your ask is, offer multiple potential availabilities for the recipient to choose from, and also indicate flexibility if they're unable during those times. So what I try to do is, say I'm available on these times and give a wide range of times for that person to choose from, but then also again, include towards the end, like I'm also very flexible and I'm open to figuring out some other times if this doesn't work with you. Yeah, I think I'll hand it back off to you.
Okay. And just one thing, one of the things in terms of those, you guys are going to be asking for letters of recommendations. And it may be someone that you kind of know, or you don't really know, or you may know a little bit better. That's really important to change that subject line, because I've seen students that wanted something from us that I would be glad to do, but because the subject line, and I have another 100 to go through, that got passed and we missed the deadline. Okay, subject lines work, even though, it's a little bit more work on your part, but then you're doing the asking, especially if you're doing the asking. So and a lot of the folks that you've met, you may be able to get a letter of recommendation from them. You may be able to develop a dialogue with them, even if there is a Zoom meeting with one doctor or two doctors or one of the other speakers. You may be able to set that up, and so that they get to know you, so you have a better chance of them, if you of an ask for support or admissions or whatever you're trying to do, you get a better chance if you change the subject line so that they know what they're doing. I can tell you, especially with these admissions folks, it really works. Okay.
I'm going to add one more that I think.
Okay.
Go right ahead. Okay. Formatting is super important. Use breaks when you're writing your email. It is so overwhelming when you receive an email that's like just one big chunk of text. Use breaks, like separate by paragraph. And I always say that a paragraph does not mean a real literary paragraph, just 1 to 2 sentences by topic, just try to give the reader breaks in between. It makes the email read so much better, and it's less overwhelming for the reader.
And also color. You can, if you got something, the other thing is that if you have something and your email is like, let's say it's 8 sentences and you have 2 paragraphs and you want the person to respond. So maybe please let me know by as soon as possible or by April 27th, and put an underline and either bold it or make it red. So that person will go to that, because you are the one that wants something and they will give it to you. It's just that you need it timely, so that, hopefully that helps too.
Yeah.
Okay, anything else on that? Anybody else want to chime in? Does anybody have any questions so far? Okay, so now we wanted to get to the whole virtual and other communication. So I think Carolyn and Tracy, Miss Carolyn Washington and Miss Tracy Broadhead Frick will be the ones who can articulate that the most, since they've been doing it.
Thank you. Thank you for this opportunity. I've been in virtual world for 2.5 years now, both for work and any personal events. So believe me, I've learned a lot along the way. And I just thought it was really important to share it with these folks, these young people, because first impressions are really still a thing. And as much as we don't want to believe that we can be who we want to be, that's true. But I think one of the former speakers said the medical admissions process is old school. So we still have to remember how we are interfacing virtually is really important. So I would always say for any Zoom meeting, any attendance or interviews, any sessions that you are going to participate in for Zoom, arrive early. Arrive early, set your camera up so that you can see yourself before everyone else gets on, that you are camera ready. That means your camera needs to be on. And the reason I say that, this is the one place that you can take advantage of, no mask, and they can actually see your face. They can see your interactions. They can see your expressions. They can see when you're confused and you need more time. They can see that you are engaged in the conversation. So it's really important. Be ready. Be ready so you don't have to get ready. Y'all know that. Just take the steps to get prepared, just as if you were going in and meeting that person in person, right? Put your cell phone on silent, please. So when you're speaking, when you turn on yourself off of mute and you're speaking, your friends aren't calling and you're distracted by looking at your phone or your watch, because I do that too. Just be aware that folks are watching you. And I know Zoom can create anxiety. It can create this feeling of everyone's looking at me. There is an option if you're in a group setting that you can turn your camera off of yourself so you don't see yourself, but the other people see you. That's really a helpful tip, because I have people that I work with, my colleagues, who just do not turn their camera on because of Zoom anxiety. But what they can do, and we've encouraged them to do this to encourage that collaboration, is to turn your camera off of yourself, but allow others to see your bright, shiny faces, okay? Please do not interrupt speakers. I think the chat box, the raising hands, the emojis are really beneficial. Raising your hand allows the speaker to see you, even though you can't really tell. When you raise your hand, you go to the top of the picture frame in the view. So your hand being raised will kind of put you at there you go, at the head of the class. And that symbol is there for the speaker as well, okay?
Could I add just a couple of things to what you're saying? I want to make sure everybody knows how to hide their self-view, right? Yeah, so in the upper right-hand corner of your screen, those 3 little buttons, hide self-view, that's how you hide your self-view, right there.
That's it. So you don't have to look at yourself. I know I have days when it's a bad hair day or I just don't like the outfit, but I'm ready to go. I just turn my camera off of me because I don't need to look at me. I know what I look like.
The last thing I just want to add to your Zoom tips is we want to make sure that you're not doing this or that you're doing this. So a lot of y'all right now kind of look like this. So if you are really trying to make an impression, this probably isn't going to do such a good job of it. So what Ms. Washington said about getting ready, make sure you're positioned right.
That's right. And that also includes being this close to the screen. Okay. I mean, we do want to see you, but we don't need to see you that much. So just really practice and find your best light, find your best spot in the house, find where you have the best reception so that, you know, wherever you are, you can be heard and be seen. Okay. I know sometimes it's a challenge. You can use your backgrounds efficiently to blur out your backgrounds, and so there's no distractions behind you. If you have a special color, a blanket, or a sheet that you want to put up for your background, thank you, Tracy. You can do that as well, but be aware of that. Be aware of those in the background. I've seen people change their backgrounds to rooms that they imagined they would be in at that time. So you have options. There you go. You have options. Take advantage of them. Those are free on your Zoom connection. And then my last part is on telephone tips. I know sometimes, a lot of times, we don't like to talk on the phone anymore. People don't like to just call. But again, medical school is old school. So you may need to call someone, and that person may need to call you back. Make sure your voicemail is not full. Make sure they have access to you. Make sure your message on your voicemail does not have the beat rocking in the background, okay? Old school. Make sure that you can be heard, that your message is clear, and that you return the calls in an appropriate time, like Dana said, in a timely manner. And that's not, oh, I'll get back to them. It's, oh, yes, I better call them right back, okay? That's really all I have. Be professional in all you do. And always, if you need help, if you need assistance, we're here. You can try it out on us. We'll take the practice with you. That's what we do. So please take advantage of it.
I'm going to
add, can I just add one more thing to her conversation? Do you mind?
Yes.
I would say 30% of the students, when we sent them their emails, it went into spam.
Mm-hmm.
And when it goes into spam, some of your email boxes hold spam for 10 days, apparently. And then the message is gone. So e-flyers, files like what we would send or medical school would send, if they're sending an email, may go into your spam. And it's very important to check your spam frequently, and particularly if it's going to be a file attached to it, because it will be gone. 30% of you had that. I have sent our email information back so many times, and particularly this year, and I don't know, maybe it's because of Zoom, but this year was massive. And it was a lot of work. Devonna, who works with me, she's just like blown out. She's like, can they please check their emails and their spam box? We're sending them a large file. So I just wanted to remind you guys that, and you can change it. I don't know, maybe Carolyn and Tracy know, if you can change those spam boxes so that they can stay in longer and not dump out. But I've heard a number of students, some of you guys have older phones, so if you have new phones, and they're all different things, types of phones.
I do actually have a suggestion for that.
Okay.
Thank you very much. One of the suggestions is to make PMF a contact in your system, so that your systems, whatever you're using, your email, your text, what have you, will recognize PMF. And then it won't go to spam from there. But your spam settings certainly can be changed in your settings so that you can change it so that it doesn't delete automatically. I've got about 2 minutes to wrap this session up. And go ahead.
Adriana has a hand up. Yes. Let's see if we can address her question.
Hi, I had a question about with particular like programs and opportunities, when you do an interview, and in my case, they told me that they would let me know whether I'd be accepted within a week, and it's already been a week, and I haven't heard anything. What should the format of my email be asking, if I'm accepted or not without sounding impatient.
You want me to take that? Okay. My question to you is, did you check your spam first?
Yes, I check it on Mondays and Fridays.
Okay, but you should check it a little bit more frequently. You should check it every day if you're expecting that kind of, because that's an important notice. And I would check it a couple of times, okay? Because you don't know what kind of, how big that is. The other thing that is important, and then I'll get to, is that if you're checking it on your phone, it's different from checking it on your laptop or computer. So be sure to check both, okay? Because it may somehow or another, I'm not good at this, but sometimes it doesn't show up. But if you have not heard in a week, and it was from a medical school?
No, it was this internship opportunity.
Internship. Oh, okay. Was it with a medical school or an organization?
With a university, yes. A medical school, yes.
Okay, you need to check your spam. I got a funny suspicion within, if let's say they told you 7 days and you haven't heard from them in 10 days, I would expect, and then look at the time frame, because they may have a response time. I would just make a nice courtesy call. This is where a call comes in versus an email, because they may be sending out hundreds of those. If there's a phone number and you can call and check, I would call, okay? And then I may do both, send an email too, but check, because whatever they may have sent you may have been an attachment, and it may go into your spam, and then it could drop off or something. Or maybe there was a mistake in your email address. Have you received emails back and forth from them?
Yes.
Okay, good. That's good. That's good. So I would do both. I would probably pick up the phone and call and just say, I'm excited about your program and want to get in it. And just want to know that you guys sent out anything yet, that kind of thing. Okay, but that's where you make the call. Okay, because that's where you want to get somebody, and that person then will focus in on you versus looking at our email list and getting to you at any time. See? Okay.
Thank you.
Tracy, can you wrap it up?
I sure can. I'm gonna wrap this up real quick. My last session I want to talk to you guys about is social media. And I know all of y'all are on Snap and TikTok and IG, and like you're there. You're maybe not in Facebook, but what I do want to encourage you to do is think about LinkedIn as your professional social media. That's a space where you can network. That's a space where you can present yourself in a beautiful light. Now, it goes without saying that your social media channels are part of your application to a job, to a school, whatever it is. So you better make sure that whatever you have on all of those platforms is something that you feel comfortable in representing you for whatever it is you're applying to do. And I understand that a lot of the stories disappear or snaps disappear. That's what screenshots are for, and those things do not disappear. So be very, very protective of that. I just want to quickly share my screen. And Lemmy, some of you have Lemmy as your project coordinator. She's on LinkedIn, and look what she did, which I think is brilliant. She has listed Physicians Medical Forum on her LinkedIn profile. You are all participants in this program and can do the same thing. But make sure, see, Lemmy hasn't even accepted my invitation yet. That's okay. That's okay, Lemmy, that's okay. But you can definitely, this is my LinkedIn profile right here. Create your LinkedIn profile, connect with people, connect with everybody who you've met with. It's a wonderful, wonderful way to network and stay in touch with people as well. But you want to make sure that all of the backgrounds you're using are clean and professional, especially in LinkedIn, right? But also in your general social media. I'm sure you all have heard that before. I have not hired people because of their social media profiles.
And to add to that, medical schools do check. So if you got a bunch of stuff out there, they do look at all of those social media pages that you guys have, just as Tracy said, they do sometimes check. So you guys, clean it up, make sure, because especially if you're in that 2-year window of applying for medical school, 2 years from now, 3 years, you're a sophomore or junior, watch it. So they do check. And I do know of a young man that did not get into a particular program because of some videos that was on him. I mean, he wasn't killing anybody or anything like that, but he just went wild, and he was on his IG page, and they got people that do that.
All right, so that wraps up this session, and we've got the next session to get going. If anybody has any questions for us, just drop them in the chat.
Okay, thank you. So this morning we heard from Dr. McDonald about the specialties and dealing with heart disease, and if you wanted to go into surgery or cardiology or neurosurgery, any of those. Now many of you, including your health topics, focus on primary care. And so whether you were in the mental health one or you're in one of the other project topics, the primary care specialties address all of these areas. So with that said, we'd like to introduce Dr. Catherine Malone. She is family medicine, and she is the vice president of the Physicians Medical Forum. And let me tell you, she has helped a number of students through this program and written letters of recommendation, and they've gotten into medical school. She is wonderful. So please welcome Dr. Catherine Malone.
Hello, everyone. How are you? All right. Well, I am Catherine Malone. I am a family medicine physician. I've been that for about 30-something years, which is way too long, and I don't want to talk about that. But let's talk about primary care. What is primary care? Primary care is basic healthcare rather than specialized. So it's a level of care. It's almost entry into a healthcare system. Okay, so whether it's pediatrics, internal medicine, psychiatry, OBGYN, it's basically the entry into those levels. And I'm going to give you the formalized version of it. So pediatrics is basically 0 to 18 years of age. Then there's internal medicine, and that's usually 18 years of age until. Then there's something called family medicine, which is what I do, which is a little bit of OBGYN, it's a little bit of deliveries, pediatrics, and adolescent and adult care. And then there's something also called med peds, where you're boarded in pediatrics and medicine. So you will do basically 0 all the way through geriatrics. Basically, I went to Smith College. I'm an American Studies major. I went to Case Western Reserve Medical School in Ohio. I did my postgraduate, my residency at University of Connecticut. And then I came out here to Oakland, and I joined 2 other African-American women who were practicing primary care. And I did outpatient care for about, I don't know, let's say 15 years. During that time, I also worked part-time at Santa Rita Jail. Then I joined a corporate-based medicine group, Sutter, and I was there for about 10 years. And now I work with John Muir. And I'm going to hand it over to Katrina Peters. Dr. Peters, would you like to talk about primary care?
Hello, everyone. My name is Katrina Peters, and I am a psychiatrist. And so I know many of you all might think, well, wait a minute, I thought psychiatry was a specialty and not primary care. I'm going to say that depending on how you look at psychiatry, psychiatry often sometimes are people's first contact that they may have because of mental health issues. And it's important for us to also understand what else is going on medically with them. For myself, particularly, I'm a professor of psychiatry at UC San Francisco, and my place of work is San Francisco General, or Zuckerberg San Francisco General Hospital. And I do have a subspecialty in forensics psychiatry, but most of my career I worked in general psychiatry and often in emergency psychiatry, where it's very important for you to look at what's going on with people medically, their medical issues, in addition to their mental health issues, and how they are impacting their care. I initially trained in internal medicine. So my view of psychiatry and mental health is it's really part of your whole general health, and that you really can't separate, in my opinion, your physical health from your mental health. They work together, and it's important to understand that. My training initially, I went to Princeton undergraduate school where I majored in physiological psychology. And I then was not sure at that time I wanted to go to medical school. So I actually took a year off where I worked at a halfway house for recovering alcoholics. And I also took some of the classes that I was missing. And these days, a lot of people have formal post-bac programs that may help people transition to prepare for medical school, but they didn't really have those then. So I kind of created my own and took some courses at NIH, et cetera. And then I applied to medical school, and I went to Howard University, College of Medicine. And as I said, when I initially finished, I trained in internal medicine. And as I was working in internal medicine, I found that so many of my patients had issues that were affecting their ability to take care of their health. And most of those were mental health issues. So as I tell people, I added psychiatry. So I then they had a special medical psychiatry transition program that was in Boston through Tufts University. So I took their 1 year, and then I completed adult psychiatry. I was in Boston for a number of years, and then I came here to San Francisco a few decades ago. So that's kind of and I've been there in some form or the other since then. So again, although I think a lot of times people don't think about psychiatry as being primary care, there are many elements about the aspects of psychiatry and how people come to you that you may be that person's primary doctor, even if someone doesn't have other medical issues. Thank you. And Dr. Malone.
Oh, thank you very much. Dr. Miller, would you like to give an intro?
All right, thank you, Dr. Malone. Welcome, everyone. First, I want to apologize because I'm having some bandwidth and unstable internet problems. And so if it doesn't hold up, I may have to turn the video off in order to have sound. It's nice to be here with you again. Some of you may remember that I was with you last week and we talked about residency, which was the next step in your training for medical school. And this week we're going to talk about what happens after you finish your residency and careers. To remind you, I am Dr. Carol Miller, a pediatrician. I am a professor of pediatrics at the University of California, San Francisco. I'm sort of semi-retired. And my my training pathway, I'm from Missouri, and my undergraduate training, undergraduate degree was from Stanford, and I stayed at Stanford University here in California for medical school, and did all of my post-medical school training in San Francisco in pediatrics, as well as a fellowship in neonatology, which is a specialty of pediatrics that is focused on the care of newborns. My decision to be a pediatrician is because I really was interested in, I like the science of pediatrics and taking care of children. I like the challenge of it changing, because children and their bodies change from newborns to 18 years of age. So intellectually, that was a challenge, and I liked that. I liked that strong developmental piece that's part of pediatrics. And I liked caring for families. However, I liked looking at that from the perspective of the child integrated in the family. So those were and I also like the idea of starting at the beginning. You know, at the beginning, this new undifferentiated little person, parents who are excited to do the best for their kids. And I felt like it was really an opportune time to maybe have some impact that could be lasting. And that actually turns out to be true. And there's actually some science behind it related to the physiology of bonding, which we won't go into. But anyway, taking advantage, you know, I felt like taking advantage of that was my best chance for having an impact. And it's been a wonderful profession for me. It's right where I needed to be. Pediatrics, as you heard earlier, focuses on children starting at birth and going to age 18, in some cases 21. Primary care pediatrics is often called general pediatrics because we take care of, we're the first step of access of care, and we are generally connected to our patients through the continuum of their pediatric age group, children to adolescents to young adults, taking care of the holistic sort of scope of their needs. We're the ones that would decide if a subspecialist, a pediatric subspecialist is needed. For example, if it's a heart problem or an allergy problem, or they need a surgeon, a pediatric surgeon, or they need some behavioral and mental health issue, specialty access. We would make those referrals. What is unique about pediatric primary care? We focus on growth and development. Those are really, really important issues. And so we do a lot of screening and with that in mind. We also do preventive care. And one of the biggest preventive care, and you guys can start thinking back on your own experiences as children going to see your pediatrician, the dreaded shots, the immunizations, is a big part of our preventive care strategy as well. Okay. Social and behavioral elements of development are important areas that we focus on with our children, both assessing how they are managing in their social world and within their families, but also helping parents create an environment that's safe and supportive and will promote a healthy development of social and as well as physical functioning. So we do a lot of that kind of stuff. We get really close to our patients. We get really connected to our patients. Just before I came on, I told you I was retired. I'm not really seeing patients in clinic anymore. I do see babies in the nursery sometimes, and I do some teaching. But I just got a text from a family that I was caring for before I retired. They sent me their Easter Bunny pictures and wanted to invite me to my ex-patient's communion. So I get a lot of those kinds of things. I had all of that when I was in practice, and I'm still connected now. Many families tell me that they see me as part of their family grouping. So I get notices and I get included in all those kinds of celebrations. Because there's a finite time frame for which we see our patients, and then we transfer them to an adult family, either family medicine or internist for ongoing care. We also have an opportunity to care for multiple generations. And when I retired, I had many families for whom I was the grandparents' pediatrician and the parents' pediatrician, as well as the children. So that long-term generational, intergenerational experience I found was very helpful in my understanding the family, developing some credibility with the family, and being able to care for them in a more individualized and impactful way. So I think I will stop there as an introduction to pediatrics and hopefully stimulated some enthusiasm for that specialty. Oh, I know what I wanted to tell you. So to become a pediatrician, there's a 3-year residency with a 4th year optional chief residency. And then if you want to do a subspecialty, you have to do a fellowship that could be anywhere from 1 year to 4 years, depending on the subspecialty. So the subspecialties are all the ones you have in adults, with the addition of behavioral and development is actually a subspecialty of pediatrics. All right, so do I pass it on to the next person, Dr. Malone?
Thank you, Opal. Thank you, Dr. Miller. I would like Dr. Godzich. Did I get that correct? I apologize if I mispronounced your name, but I'd like you to give us an introduction.
Thank you so much. You did get it right. I tell my patients God's itch, like an itch.
God's itch. Okay, got it. Thank you.
Thank you. My apologies for coming on a little bit late. I happened to be on call and I needed to step away. So I had the pleasure of being here last week and I liked it so much that I decided to come back. So thank you for the invitation and the space. I am a family medicine physician. I am a faculty member at UC Davis, and I also have a primary care clinical practice at a local federally qualified health center in Midtown in Sacramento. And I am very passionate about family medicine as an opportunity to really create relationships between patients and the healthcare system and bridge some of the ways that healthcare has not been as helpful to people as it can be when it really is effective. So I mentioned this last time. I actually went to medical school thinking I was going to be a trauma surgeon. I was, the head of the surgery interest group. I hung out with the chair of surgery and surgery with her. And I took trauma call and I did all the things. And then when I got to surgery, I just did not find that the type of care that was being provided in that space was the type of care that got me interested in why I went into medicine, because medicine's hard, right? So the work is hard, it's tiring, it's demanding, and it's so rewarding when you are well aligned with the values of the type of work that you're doing. It is so worth all those sleepless nights if you believe in it. And so finding your home can be very important. And I happen to find my home in family medicine. And I think it's because family medicine is something that is anchored in relationships. It's about meeting people where they are, with an emphasis on the relationship and what is going on with the patient versus what is going on with the disease or the condition or the body part. And that is the heart and the soul of primary care. And I think you've heard it from the other people who spoke today. It is about those relationships and the opportunity to determine with the patient what they need and help them achieve that. Because they're the experts in their bodies, but you're the expert in the conditions that their body is experiencing. And then you can partner in a therapeutic way with them to really move with them towards their goals. And that is what I find beautiful in primary care. And it doesn't matter if it's pediatrics or internal medicine or family medicine, those relationships are what makes the practice so rewarding. Within that, in family medicine, you have the opportunity to work with a variety of people. And I'm currently on obstetrics call at the hospital because I do deliveries. And a large part of my practice is prenatal care. And I enjoy prenatal care tremendously because it is a time in people's lives when they are very receptive to thinking about how to care for themselves and how to think about things differently. And they are really interested in living in different ways. And the opportunity to engage with someone over the course of 9 months, and then if you're lucky, get to be there at the time of the birthday, and then get to see them in clinic and do the well child care and see the mother back, and screen for preeclampsia after delivery, screen for postpartum depression, and then invite that person to tell you how it's going at home, and say, oh, it sounds like your partner might have postpartum depression. Tell them they can come see me, and be part of that family story. That is what I find remarkable and such a privilege in family medicine. You have the opportunity to be there for people in so many different stages of their life. And I have definitely had the opportunity to join into the care of a family member simply because I was legitimized by caring for another family member. Suddenly someone who is not someone who usually goes to see the doctor, well, their sister vouches for me. So I get to be the one who has a conversation about the fact that maybe we want to try and do something different around substance use disorder, perhaps. And as a family doc, I have that scope of care where I am able to start the interventions and determine whether or not we can assist them in that outpatient setting, or if they need a specialist. And that's really a gift as a family doc. And what I joke about with a first-year med student who might be considering family medicine is, we're the kind of old school docs that your grandmother talks about when she's talking about a doctor. And we take care of 85% of the things that come into our door, and we know when to refer for the remaining 15%. And that's a gift. And I really, despite the hard aspects of being a family medicine doc, all of those opportunities to connect with people really make it worthwhile. So I think we mentioned last time, it's a 3-year residency. There are a couple of types of fellowships you could do. You could do a fellowships in obstetrics. You could do a fellowship in addiction medicine. You could do a fellowship in palliative care. But generally people do 3 years and then they go into practice. And your practice can change over time. I have practiced in small rural towns of less than 1,000 people where I was doing everything. I was doing C-sections in that town. I was staffing the emergency room. I was doing home visits. I was doing skilled nursing facility. Now, because I'm working in an urban setting, I mainly work in the outpatient clinic, and I do take obstetric call. I used to do inpatient medicine, but I've had to reduce that because I prioritize teaching and spending time with folks like you. So with that, I will end and let others share.
Dr. Malone, may I say one more thing about primary care just in general that I think hasn't come out, that we all do, no matter what vantage point that we come at it. And that is, I wanted to mention our role in helping patients manage their chronic illnesses. They may see a specialist who gets them started, gets the diagnosis made, gets them started, but coordinating the care and helping patients manage their chronic illness on an ongoing basis is generally the purview of a primary care doctor. And coordinating all those different subspecialists who the patient's seeing and helping them figure out how to make that work in one body.
I agree with you.
The
I think
different
sometimes
recommendations that are happening. Yeah.
I think sometimes I think of myself as a conductor, symphony conductor, but trying to get all these different parts of the patient's specialists together, including home care, nutrition, all of that together to basically make a symphony. So that's another way that I've looked at it. So now that you've heard all of us, we should have lots of questions from you. So fire away, I think. No questions. Everybody understands this.
I think Mariah has her hand up.
Oh, I'm sorry.
Okay.
I didn't see you. Sorry. Okay. Mariah, please.
Hey guys, thank you for this. I guess my question is more general. So how would you from my understanding, like specialists can actually be primary care physicians. Is that correct? Or how would you draw the line in between like specialist and a primary caregiver? And how do can they actually like intersect?
Does anybody want to take this, or?
Probably we all could, but it's a very good question. There are many, there are physicians who practice both primary care and a particular specialty. For example, in my case, I did primary care and neonatology, and I've always done that. And I was able to make those two work, even though people say, well, that, one's a really intensive inpatient specialty, and the other is what some people say was the opposite. But for me, it worked very, very well. In the Kaiser system, and I don't work in Kaiser, so I may be speaking out of turn, but my understanding in the Kaiser system that is a large group organization where it's not at all uncommon for some primary care doctors to also do specialty clinics as well. So it can happen. I may have mentioned this last week when I was with you guys last week. Medicine, the beauty of being in medicine is that if you can conceive it, there's probably a way you can make it work if that feels like the right way in which you want to do your career.
I agree. I think for all of the internal medicine specialties, they have to do 3 years of internal medicine. So they have completed their primary care internal medicine section. Then they go on to either cardiology, neurology, all the other ology things. So they still have their general expertise too. But typically, usually when someone specializes, then they go off into just one section. So they just do the heart or they just do the brain. Since I'm a primary care doctor and I like looking at a lot of different things, I don't like that sort of thing, but that's the way I would describe a specialty if you're asking the difference. Anybody else have another way of looking at it?
I mean, I think the specialist is someone who, for example, if you're a primary care doctor who is managing diabetes and you're unable to get it under control with, the conventional meds, you might send them to an endocrinologist for a consultation. And then they'll make recommendations about the treatment, and then you can apply those recommendations in your primary care practice. And so typically specialists have a little bit less of a longitudinal over time relationship with patients. And if they do have a relationship, it is within a specific discipline. So it's like within, the management of this condition. It's kind of going back to what I said before about primary care docs work with patients, and other types of doctors work with conditions or diseases, or so that's one of the ways of making the distinction.
Dr. Malone and panel, they have team projects. And maybe you guys can address how the primary care doctor would work with, and I'll give you a couple of the team projects, the other doctors that treat your patients. So one of the couple of team projects include cancer, orthopedics, infectious disease, women's health, OBGYN, of course, heart attack, and they heard from Dr. McDonald this morning, and then mental health. And then, of course, neurology and the brain and so forth. So those are the 8 topics. So how does the primary care work with the other specialists to provide the care and the hopefully health and wellness that the patient may be trying to, you're both are trying to accomplish? How do you tie that together?
Well, I think the example that was just given about diabetes is a really excellent example about how a primary care doctor coordinates with a specialist. And we do see that in pediatrics as well, is that the primary care doctor may may use a specialist to help in situations where the usual approach to a particular disorder may not be working as well as we would like. Or perhaps the specialist is more skilled at a particular procedure. If I have a patient who needs their tonsils taken out, I'm not going to do that. I'm going to refer them to a specialist who will do that. And I may pick them up afterwards and do the follow-up and make sure that they're recovered. And if there's, follow them for any other complications they might have or might develop. But I'm not going to do the surgery. So there's a lot of coordination that goes on. If I want to bring Dr. Peters into this, who's a psychiatrist, if I have a child who has need of some more intensive work around their mental health issues, I may use a child psychiatrist to do some of the more intensive work, but at the same time, we will coordinate and support that care. So there's lots of examples in which we coordinate, and the specialists themselves, they have defined their boundaries of how they work. And they, in my experience, really require patients to have a primary care doctor, which is why they often, the pathway to a specialist, a subspecialist, is going to be by a referral from a primary care doctor. You can't just walk in, you just can't call up a cardiologist and say, I want an appointment because I think I need a cardiologist. As a patient, I mean, you have to be referred.
And I know with the last question, I thought of one of my patients who I was working with yesterday. They have cancer and they're seeing all the cancer specialist and all this, and then the surgeon to get the report in. They're doing all these other things. But when they came into the office, I asked them how they were doing. Because sometimes the specialist is looking at just one thing, the cancer, the heart. But this is a whole body. This is a whole person who is a mother or a grandmother or a daughter working with a whole family unit. And you need to really look at that. And I think that's what a primary care doctor does. I don't want to just know how the cancer is doing, but how are they mentally handling this? How is it working with their families? How are their families reaching out to them? What about health maintenance? We still have to make sure that their mammogram is done. We still have to make sure other things are done. We can't just ignore that. And I think that's something that a primary care doctor does. We look at the whole body. We don't look at just one organ system and realize this is a human being. And that's the difference that I see from primary care and specialty in general.
Can I share with you a framework I talk about with medical students who are not sure what they want to go into? Ultimately, you can choose whatever you want, like whatever you choose to do, it will be amazing to have you in that field in medicine. Please don't feel any sort of pressure to end up in anything. And really the work to do is to find out what you enjoy. What is going to get you up at 3 in the morning? What do you care about? What makes you excited? And there is a framework you can think about categories of specialties in medicine, and that is being a diagnostician, someone who gets satisfaction from figuring out all the puzzle pieces together. So that would be like someone who's a radiologist who looks at like pictures of people's insides and says, ooh, that means that this is this condition. Or an emergency room doctor who sees someone who comes in and says, I have pain, and gives them a diagnosis. But these people don't follow the patients over time. So their satisfaction is from being a diagnostician, and a pathologist is a diagnostician. Then there are the fixers. If you're someone who likes to see something that's broken and fix it and then walk away, that is a very important role in medicine. And those are the surgeons, those are the orthopedic folks, those are, the people who go in there, identify something to fix, and then they're done and they move on to the next one, and they get tons of satisfaction out of that. And then the last one, and this is where I put our primary care docs, we're the managers. We are the people who manage conditions over time with people, determine what people want, how they want to live, what their goals are. So for example, the best medication, the best on paper for a person, to go back to the diabetes analogy, might be insulin. But if they are afraid of insulin, it is not the best medication for them. Right? And as their primary care doc, you know them and you create a relationship that allows them to say that to you out loud. And you determine, okay, maybe the books say I'm supposed to put this person on insulin because their hemoglobin A1C is 11. I'm not going to put them on insulin because they're just never going to pick it up and they're never going to get back to me because I didn't see them as a person. So I prescribe them 3 different types of oral pills that they can take to bring down their sugars, and we see where we go from there. And we talk about other things we can do. And that's that management of meeting the person where they're at and maybe thinking about doing things differently based on what the patient needs. And that is a little bit of a distinction with a primary care doc who has the relationship over time to know who that person is, what their community is, what their family situation is.
Christabel has her hand up.
Hi, thank you so much. As you all were talking, I just thought of it as, I hope that eventually I'm able to be in a specialty that I can really speak nicely and convincingly to pre-meds. So my question would be, I am interested in research, and I was wondering, how does primary care physicians incorporate research into their career? Because I know research is usually focused, but primary care is broad, as we are learning today. So I just wanted to hear your thoughts about how to incorporate clinical research into your practice as a primary care physician.
Oh, that's absolutely possible. Absolutely possible. You just happen to have 3 people here who get a lot of satisfaction with working directly with patients and caring for patients. There are, and in general pediatrics, there's a term called academic general pediatrics. And these people are usually associated with an academic center or university where they can get grants and they can explore all kinds of things. They can explore research and quality of care, preventive care. There's all kinds of questions in preventive care of children that we still need to have answered. And they do that kind of research. And there's a lot of need for it. There's grants for it. There's positions for it. And there are lots of people who are doing it and contributing greatly to our understanding of how best to take care of children. And I'm sure that that's true in adult medicine as well, that, that the same kinds of careers that focus on research are there.
Anybody else?
A lot of primary care research is also focused on epidemiology, population health. And so, one of the things that we have the privilege of doing is kind of getting a sense of where people are in their environment, because we're in a community and we see people from all aspects of the community. And so, you think about, Dr. Miller, you're going to have to remind me of her name, the pediatrician out of Flint who recognized the presence of lead elevation in the kids. She
it's Flint, yes.
Yeah.
And yes, and my friend, yes.
Of course, you know her. Yes, personally. Yes, of course. Well, I mean, so that is a form of someone having that intellectual curiosity of doing the research on the community and saying, there is a pattern here I need to follow. And that can emanate from the actual practice of your field, including in primary care. So if you have that mindset of saying, oof, there's a question that's coming out. Why? What is happening? Why? Let me investigate. It can absolutely be applied to the framework of primary care as well.
Denisa has a question.
Yeah, I'd like to say just a little bit more about that. This is Katrina Peters. I just wanted to add on to that. is that in addition to people doing more academic research within a university where they are leading the grant, there are also opportunities for some clinicians who are working in their office to participate in clinical trials. Mm-hmm. And those trials are actually, those are research that has been developed by another entity, but it's important when at different phases for them to actually have direct access with patients. And clinical trials where they're involved with a physician in the community can also be another way in which you can marry the your care of patients in primary care with research.
All right, now Denise.
Let me just add, would one of you explain, the primary care doctor is the person that provides the referrals, because a lot of these students want to go into one of your fields. So the referral is the glue to get you to the next person. Would somebody just talk about that? Because that needs to be, cleared up a little bit. And then there's two other people, I think, that have their hands up, at least two.
Okay. So in primary care, if we feel that something, we can't manage it, or we want to get assistance in managing something, we usually refer out. So for example, if someone fractures their arm, I don't really know what to do with it. I usually will refer it out. Or if someone's having chest pain and I think that's as cardiovascular disease, I'm going to refer out. And I think that's what you're asking. And there's another question on the chat, and I'm going to try to address that before I get to the next question for the person that's holding their hand up. What do you do if your primary care doctor is not listening to you? I think that's one of the questions here. I mean, we don't live in a rural area where I'm the only doctor in a 100-mile radius, so you have to deal with me no matter what. If your doctor is not giving you what you need, then you need to find another physician. I love it when people say, hey, I want a second opinion. I love it because I learned something from it. I don't take it personally. Like, hey, if I'm not giving you what you need to find somebody else. Or sometimes our personalities don't get along. Sometimes people just don't click. If that's the case and you click with this other person, I couldn't be happier. Get the healthcare the best way you can from the person you can listen to and take their advice. And so that's the way I would handle that. But anybody else?
And that could be you as the doctor too. That could be them as the doctor, right?
Well, that's true. That's true. But I'm a kind of person that says if something isn't quite working within a relationship, you at least take a first stab at trying to repair it. And that is, give the person a chance, have a conversation. I really appreciate your expertise. I'm not sure that I'm really being clear about what my needs are. Can we have a conversation and see if we can get on the same page and see if there is a response? And then if that doesn't help, I agree. You have many, many options and choices.
Okay, now we can take the question from Denisa. Here we go.
Thank you so much. And thank you to all of our panelists. I feel like listening to all of you, I'm like, yeah, primary care sounds pretty cool. Sounds great. And my question is actually for Dr. Peters. I was wondering if, as a psychiatrist, if you're working with your patients long-term, like perhaps you see someone as a young adult and then into their adult life, or maybe you see middle-aged person into like more older ages, for example. And also, I was curious if you could speak a little bit about like how, if with your patients you are seeing like that they're able to successfully manage conditions like maybe severe mental illness like bipolar disorder. And I know this is a lot. I was also interested why you chose forensic psychiatry as well. And I can clarify any of this too.
Hey, thank you for all of those questions. Let me say first is that it is possible to follow a patient in psychiatry for many years, but that's usually in an outpatient setting, where you're seeing someone. And it also speaks to the fact that there are a lot of psychiatric conditions, especially serious mental illness, that are actually chronic conditions, which means that it's something that you are going to have to manage. It's not a cure, but something that you're going to have to manage over time, and your needs can change over time. Because of the setting in which I work in a hospital setting for patients who are on an acute psychiatric unit. So I don't work with those patients for a very long time, only for the amount of time that they're on my unit. Because again, when I spoke about there being chronic conditions, sometimes those patients get readmitted to my unit. And so in some ways, we have somewhat of a prior relationship, but it's not the same as what you're talking about when you have an outpatient that you're seeing over many years. I actually, through the years, although I primarily worked in hospital settings where you don't have that outpatient relationships, but I actually have had some time periods where I have worked an outpatient or doing consults, and those patients I have had contact with over over many years. It may be over 5 or 6 years until they move to some other area. So you can have, depending on where you practice, you can have that kind of relationship with your patients. I also, for a long time, worked in emergency psychiatry, where you're only seeing people just for that day. But again, sometimes they come back too. So there's many different settings under which you can work in psychiatry, and that is going to help dictate what kind of relationships you have with your patients. In terms of forensic psychiatry, some of that is interesting on how that came about. It's not something that I saw when I first started psychiatry, but working in an acute place like San Francisco General Hospital, I found that many patients wound up with serious mental illness and they were in jail. And a lot of times related to things because of their illness that got them arrested. And particularly I was interested because there were a lot of people of color who were being arrested and in jail. And I thought this was a group under which I could learn more about and be able maybe to help, with the idea that hopefully if you can help get people their mental illness in better control, one, they can tolerate jail better if they have to be there. Number two, maybe they can make the connections enough so they don't get in jail in the first place, or they don't return to jail. So that is some of the reasons why I later obtained a subspecialty in forensic psychiatry, which also allows you to work as an expert witness. You may have seen on TV, I don't know, you guys are too young for Law and Order, even though there's been reruns for like the last 20 years, but they have psychiatrists there who testify in court about a person's mental state. And so that's something also that if anyone has seen any of those, that is also a part of the subspecialty of forensic psychiatry. So I hope those answered your questions. If you have any more, you can contact me. I'll put my email in the chat. And I hope you pick psychiatry.
Thank you so much. I I love psychiatry. It was wonderful hearing from you. Thank you.
We have another student question, Antonio.
Hi, thank you all for the info. It's been really helpful. I just have I guess a question here. If somebody's interested in primary care and they want to be a fixer, like Dr. Godzich described, what would that look like? Is it possible?
Yeah, thanks for the question. I have a little bit of the fixer in me, and you know, as I mentioned, I was interested in surgery, and so I'm a family doc who does lots of procedures. I mentioned that at one time I did C-sections, and that is, you know, a great joy because I spent time in the OR. At one time in my practice, I had a flexible sigmoidoscopy clinic where that was all I did. And that was part of my weekly practice. And so I got my fix of being a fixer. I integrate a lot of dermatologic procedures. I do a lot of women's health procedures with, you know, IUDs and endometrial biopsies. And, you know, I mentioned removing toenails. And so there are a lot of things in primary care that you can do more of in terms of procedures that can meet the desire to have that immediate kind of satisfaction of doing an intervention and seeing the outcome immediately afterwards.
Thank you.
Dr. Peters, I just want to make something, even in psychiatry, where most people don't think about having procedures, we probably have the fewest procedures of most of the medical specialties, but even for the fixers in psychiatry, there are some procedures. There's ECT, there is magnetic resonance, electronic resonance, where people use equipment and chairs to help people to reduce their depression. There are people who are doing infusions of different medications. So although it's certainly not as common, there are some opportunities even in psychiatry.
Well, I guess I have to put a plug in for pediatric, primary care pediatrics and procedures as well. We do procedures too. So we do simple lacerations. We can do, if they're orthopedic injuries, we can splint. We take things out. Kids like to, you know, any orifice that you can think of in the body, if some child has put something in there that doesn't belong, and we take those things out. Ear infections, often one of the treatments of ear infections is to actually do a tympanesis and drain the fluid out of the middle ear for comfort. So yes, even in pediatrics, we do a lot of procedures. Take stingers out, foreign bodies out, you know, I've done all that, drain abscesses.
Yeah, that I love.
Lots of that kind of stuff.
Abscesses I enjoy, I have to admit.
Oh, like Dr. Pimple Popper.
That's fun. That is fun.
Many of the students here, I think, want to probably are looking at the specialties that you guys represent. In fact, I think probably maybe 2/3 of them are definitely interested in either internal medicine, family medicine, psychiatry. We have a mental health group. So I'm sure that they are taking note of this. And then we have a women in OBGYN. And so your responses, I hope, are helping them as they determine not only their team project, but their chosen specialty, hopefully in the future as doctors. And then there's a team, the best team, we're going to select one project to be the number one on the people on the board of the 8 that are going to be submitted. So you guys take advantage of these folks, okay?
We have another student question. We have Iona.
Hi, yes. So my question was, as a primary care physician, how do you all help your patients like in the clinic that are dealing with maybe some of those social determinants of health? Like say you maybe refer them and then they are unable to access the specialty care. So just wondering more about like what do you all maybe have seen in like your professional careers and things that you have done to help with those issues that we have.
Well, I'll start and I'm sure they'll sweep it up and clean it up after me. That is a real problem for me. It is a huge problem. It's a daily problem. And I don't see it getting any better. And it doesn't really matter right now if patients have good insurance or not. It's really a challenge and you do the best you can. But for me, it's very sad. And I know that I'm not doing the best job that I could do, but it's important to have those referrals and have them go through. And a lot of the times what I do is I just manipulate it. I will say something's urgent when it really isn't urgent, but I need to get them in more than, they need to be seen before 4 months. If it's mental health, we have a major problem in the Bay Area getting help for mental health. Unless you're about to kill yourself, there's really nothing I can do. I can give medications, but giving a referral, we're not even really allowed to do that. We're told to tell them to go to their insurance company to get the referrals. And when they get the list, it takes them months. It is a problem, and I don't know what the solution is. So I don't think I've actually helped my patients with that. I try to orchestrate the manipulation if I have to get them to the right place in the best time period, but it is a big problem. So I'll let somebody else handle it because I'm very frustrated with that same question.
So primary care physicians are advocates for their patients. That is one thing we do. We advocate for our patients, and we do it every day in all kinds of ways. What Dr. Malone is talking about is equally important, and it is a systems problem. We have a very poor healthcare delivery system in this country, and I think it contributes to the difficulty that we have in getting our patients referred to places where they need additional care in a timely manner. And that takes, I guess we could spend another hour just on sort of the systems, the system of care delivery. In the United States, medicine is often framed in a for-profit sort of mode. And when you have something that's in that mode, then everything is geared toward those activities that make a profit, which can sometimes make it really difficult to have enough availability in certain subspecialty or certain special services in order to get your patients into them. The other problem that we have, and I'm starting to editorialize and opinionize now, is that we have a very wide or large payment structure in this country according to specialty services. And a lot of times that payment structure is very influential into who decides to go into certain specialties or who decides to practice. I mean, we may have quite enough mental health professionals in this country, but they are not practicing in areas that where our patients need them. And it may not be because they don't want to, but it may be because they just can't make a living because of the way the system is structured. And that's really true in children. Behavioral medicine and behavioral health in children is really important, really needed, and there are very, very few people in that area available to provide the service that's needed because it's not reimbursed very well. So I may not be explaining this all. I don't want to take a whole lot of time, but I think you need to know that there are some really serious system problems here. And some of you may be wanting to spend your time, unraveling some of that. And I would really encourage you to, if you've got an interest in doing some systems work and making it work better for everybody, I say use your talents and think about incorporating that into your career.
I would like to address some other aspects of when you're talking about social determinants. Since I'm at San Francisco General, which is a safety net hospital, we have many of our patients there do not have all of the things they need to have a healthy life. For an example, they may be unhoused. Number two, they may not have proper clothing. Number three, they may not have proper access to nutrition, especially healthy nutrition that would be appropriate for their various illnesses that they have. So there's one area when you're in a large institution like a hospital, we do have social workers, which generally when people are in their private offices for outpatient, there's less access to that. But there have been some programs that are starting to be developed. And again, these are systems issues that Dr. Miller was speaking of related to and how things are developed. Because it's one thing for you to say, okay, you have diabetes, you need to eat fresh fruit, you need to have this kind of diet. But if you live in a place that's a food desert and there are no appropriate grocery stores nearby, if you have other issues of where you live, if your child has asthma and you're living in a place where it does not have clean air, these are all things that are going to help make a difference in how your health. So there are some things, on a systems wide where they're trying to, some of these are being done through the medical organizations to work with legislature to try to have other larger solutions to some of these problems. For an example, they have part of Medicaid, which they call Medi-Cal here in California, to be able that you as a doctor can write, quote, a prescription for certain food. And they can go to a specialized food bank and be able to obtain that food. In the hospital, we have, because of, again, the nature of our clientele, we have, they're donated their clothing carts that we may, because people may come in and they don't have appropriate clothing for the weather, and they may have access to clothing carts. They may have access where they try to find some type of vouchers for either, hotels or shelters or some other way to help connect people with those kind of services they need. But I think that all of those kind of aspects, some people say, well, that doesn't have anything to do with medicine. It has everything to do with medicine, but it also has to do with our society and what choices we've made for how we're going to take care of people. And if you do not have those healthy environment, then it's going to be really difficult for you to have a healthy body and mind.
In my world, the program called WIC, Women, Infants, and Children, we partner with them a lot. They provide vouchers for food. They provide support for women who are breastfeeding. So yes, those things are really important to good health. And that's what we do as primary care docs. We access all those, we dig them out, we find them. I'm always finding new resources for my patients to send them to, because that's what we have, that's what we do.
I so appreciate this question, Iana, and I I really appreciate my colleagues here in naming all of the ways in which doctors are involved in addressing social determinants of health and recognizing that this is, essential for good health. And I think sometimes as doctors, we want to do all of the things. And there are a lot of other people who are experts in certain areas who can also do those things well. And so some of it is also us meeting folks like expert social workers, expert registered dietitian, diabetes educators, expert doulas. There are so many experts who can support our patients' health beyond us, and understanding that this is teamwork, and we can have some people who really collaborate strongly with us to work towards that health of our patients from a holistic viewpoint. And it's not just about us prescribing medication. So thank you for giving us the opportunity.
All right, are there any more questions or comments? Because I'm sure this is a lot for a lot of you guys to process, especially the mental health and the ones who want to be either internal or family medicine doctors. And I think there are a lot of you. I see Jordan has her, is it Jordan? You would like to say something? You have a question?
Yes. I actually have a question for Ms. Godzich, actually, but anybody. So I am in my senior year of undergrad in college right now, and I have an interest in going into like OBGYN area of the medical field, primarily for the reason of, learning about the disparities in like maternal death rates for Black women. And this is for anybody who wants to answer this question also, but being Black women in the medical field, like, how do you guys continue to always assert yourselves in spaces that try to like ignore you, just how like Black mothers are ignored? Like, how do you advocate for yourself and for your patients and not let other people try to like silence you? Because that's something that I'm worried about, but something that I know I'm probably going to have to deal with when I get to that point in my life.
Excuse me, Jordan, could you put your, so we could see you if you don't mind? If you don't want to, that's fine, but it would help if we could see you.
Yes, I'm sorry. My camera has been acting up the last couple of days.
All
Give
right.
me 1 second.
All right, thank you.
Yeah, thank you, Jordan. One of the ways in which I do let people know who I am is I make sure they call me by my titles. So Dr. Godzich, and that is actually really important. It really is to just say who you are and your credentials and make sure people know who you are, and don't be afraid to name that, right? And so to this day, I still have to do that. And that is the reality of Black women in this world. And this is what we do, and it's okay. And it really is a small price to pay for the privilege of being able to help people feel safe in scary medical institutions. I mentioned that I provide care on labor and delivery where I am right now. And it is because I have a large number of Black pregnant patients who want me to care for them, and they have my cell phone and they text me when they go into labor, and they want to see me on labor and delivery because they want to be sure that they're safe. And that is the privilege that I have in this role of doing this. And in every space, there are going to be people who might look at my credentials a little bit more closely, who might forget that I'm an attending doctor, even though I've got white hair and I'm way too old for them to be questioning that, because it's not really about my age, it's about something else. And you know what? It's all good because I get to be in this space and help people. I can push through because it is a privilege to be here. And me having the chance to be here with you all, that's part of the work too, right? This takes time. This all takes time. If you all want to be inspired around the care of people in this country and how far we've come, watch The Power to Heal, which is a PBS documentary. That is a story that is so inspiring. People who are alive today talking about the integration of hospitals with the Medicare expansion and how recent that is and how far we've come. You are all part of history of making this better. All right, I'll get off my soapbox.
It's okay. I couldn't agree more. And I feel like because something's hard, because something's challenging, because we have to sometimes manage disrespect when others don't have to, is no reason not to pursue your dream. And as we, and we stand on those that came before us that opened up a little door, because people saw how competent and caring they are as a professional in medicine, that when I came behind them, it was a little bit easier for me. And hopefully it'll be even more easier for you, because if I have done my job right and I have demonstrated my competency and my unwillingness to be ostracized from this profession, no matter what, just that experience will make it a little bit easier for you to push through. So I think, it's about keeping a clear vision of your purpose, why you're doing what you're doing, and being headstrong that you're not going to let others externally come and push you aside. And the patients give you power. When you are true to your patients, they will back you up, even without your asking for it. They will come in, and when they're in spaces where you're not around, they will demand that Dr. Miller be called. And my doctor is Dr. Miller. My kid's doctor is Dr. Miller. She knows him, and I want you to call and talk to her before you do anything. Or I want to see Dr. Miller and discuss this with her before we decide to do anything. They give you that power.
I just want to say on a personal note that Dr. Miller, that is absolutely so true from someone who's had serious health issues. And I can tell you that in my personal case, my personal background, I had a lot of pain in my back, and I went to surgeons and different people, and the person that figured it out was my primary care doctor, my family medicine doctor, Dr. Catherine Malone. And I walked in her office one day, and I was just laying down. And you guys all see me, I'm very animated. That was not what she was used to seeing. So what she did was she said, "Stop, something is wrong." And she went back 5, 6, 7, 8 years, and she found the orthopedic doctor who said, "It's your neck." And so that was on September 16, 2014. And on September 29th, 2014, I had neck surgery. And I have 6 screws in my neck. My primary care, my family medicine doctor found out. Not all of the other ones. That's why I am so big on this particular field. Okay. So you guys, because it was going to ultimately, as she will tell you, maybe affect my spine, and the whole bit was going to be on bad news that was about to happen. So I've always been so appreciative of her for that. And I just hope that you guys, as Dr. Miller has so with your patients, will tell you sometimes. Some won't, but there are some of us that will. Okay. Wow, I didn't mean to be a closer.
Well, thank you, Stefana. That means a lot to me. I think being a primary care doctor also means just listening to the patient sometimes, just listening and just trying to make sense of what's going on.
What you're saying, yeah.
And I also want to follow up with something that Dr. Miller said. I think when you're an African-American physician on the on the ward, or you just have to hold your head up high. And there are times that I've probably been considered the angry Black woman, but I will challenge for a patient and say, wait a minute, if this was a white patient, would you treat them this way? And, I probably do have that label, angry Black woman. But I think if I can make somebody question their behavior, and my patient gets the care that they need, then that's what I need to do. I don't care what you label me. But I will say that when I used to go to the hospital, I remembered that I was the African-American female physician. My white colleagues were a physician. My white male colleagues were they were white, they were just a physician. My female colleagues that were white were a white physician, a white female physician. I'm sorry, I mean just a white, I'm saying confused, a female physician. But for me, I have both terms ahead of the physician, and that bothered me. African-American female physician. That's ridiculous. I'm a physician. I happen to be those other things. But I never forget that. That's what they see when I walk in. Whether
I decided, for me, I decided in that vein that, it wasn't going to go away. I'm always going to be a woman. I'm always going to be Black, and that's how they're going to see me, and they're going to put those monikers on it. So I decided to embrace it. What I found that I did not, and I was all prepared to be the doctor for Black children. That I was prepared. What I wasn't prepared for, how many non-Black parents
wanted to see you.
Wanted to see me.
Right.
For a number of reasons. Some wanted to, are trying to change the narrative for their children in a social context. So they wanted them to have that experience being cared for by a non-white male doctor. They wanted them to see that. Others, I'm just gonna say, when you get a reputation for being good at what you do, they don't care. They want the person they think is gonna do the best by their child. And so I embrace who I am, okay? That has been my experience. And there's just there's no taking from you your skill set, your integrity, your respect for others that you display. When you do that, it begins to transcend all. Not everybody, but enough that you're making a difference. So I just embrace who I am. And says that's where you see me, then I'm going to use it to my advantage.
Does that help you guys, you students? How is that? Any comments? Any questions? I think you guys have closed it.
Okay. Can I say something about that first half hour the first
Sure,
workshop that
go
you did
ahead.
earlier? I didn't see all of it, but I heard a bit, and I just want to say that this issue about technology is so important, and I'm so glad that you guys did that session for them, and I hope they took notes. And I want them to understand too that even if the pandemic goes away, and I say even if because I don't know that it's going to go away, but even if it does, this move to incorporating technology into medical care is not going to go away. And being able to be facile and professional with your patients in a variety of medium besides in person is going to be very, very important. And how you present yourself is very, very important. And those things people can find on the dark web, anywhere. So just, you just really need to take this seriously and understand that just like you wouldn't walk outside your door naked and running around, you don't disclose things on any format, because not only are people who are interviewing you and making decisions about your next steps in your career looking at what you post. Your patients are looking at what you post.
Okay. Dr. Malone, anybody else have any other comments? Any other questions, students?
Yep, best of luck. Thank you for joining us. If we can answer other questions, let us know.
Okay, thank you for the chats, all the links in the chat. Thank you so much. And with that said, I think this is it. We have students, we have one more thing. Thank you, panel.
It was a pleasure. Dr. Gottschalk, good to see all of you. Dr. Malone, Dr. Peters, bye-bye.
Bye-bye, thank you. We are about to come to, I'm getting hoarse. We are about to come to the conclusion of the day. I just have two quick things. We have everybody who has said that they wanted to sign up for the internship program that Dr. McDonald mentioned this morning. I think there's 16 now. And then the last thing is, if there are any project coordinators, do you have any announcements? Stephanie, starting with you. Any announcements? We're not going into breakouts for your team. Dana, any announcements? Who else is on? Damon, any announcement? Real quick.
Just a quick announcement. Double check your emails if you haven't responded. And now for neuroscience and for mental health, we have a Google Docs up. So if you have any news articles or any ideas, just like type that in there, communicate with each other. I think for both groups, we're still waiting for a couple people to start a group chat. So please respond. Communication is needed so we can win that money. So, and do a good job. So, all right, that's it.
Okay, go on. All right, Devon?
Hello, I don't have any real announcements for my group. We've already been in communication. I wanted to ask Alfana, have there been any updates on the students who did not come from last week?
Let me talk to you about that after this, okay?
Okay.
So hang around, okay? Dana?
Yes.
Any announcement?
So I sent everything really over email, so make sure that you're checking your emails. I know that my women's health group is going to be meeting today, so just make sure after you meet, you send me everything that I asked for in that email, just summarizing things. And feel free to also add me to the Google Doc that you guys have if you want me to review things on the Google Doc as well. And yeah, let me know when you all want to set up a Zoom meeting so I could get the link set up.
Okay. All right, because remember, it's a team project. And I think at this point, if a person has not responded to the team project, you guys don't have it, we'll make a decision. The team project coordinator and myself will make a decision about that person in terms of the internship part of this whole program, because you need to move on. As you can't penalize the rest of the team, okay?
Can I say one thing also?
Yes.
I think at this point, everybody is present and everybody who was absent last week is going to be participating. And so make sure that you're all connected. Those 4 people who were absent, make sure you're connected with the group. And group, if you haven't heard from those 4 people yet, please let me know so I could follow up. Thanks.
Okay. Yeah, and make sure they should be either emailing you or calling you or communicating something about what's happening with them. If they've gone ghost, okay, so you just let me know, or let Dana know if they're ghost. You haven't heard anything. And Tijan is not here, and I think Lemmy is in our clinic today. That's why she's not here, because she's at UCLA, but she knows the drill on this. She's done it before, okay? And then the last thing is the parent workshop. I'm assuming everybody's parent or family member or whomever has registered. But if somebody definitely wants to register, and I think the deadline is it today? They need to do it today, because we're going to make a final list for the parent family future doctor workshop next Saturday. Next Saturday is going to be your last day for the actual workshop, the Doctors on Board program, and it should be really good. So hang in there, and I think that's it. Carolyn and Tracy, you got any comments?
No new comments.
And no advice? Okay. All right, I think we are finishing right on time. It's 2:57 California time. Thank you guys and great job, great questions. Thank you.